And I am the chair of the commission. I want to thank everyone for attending. The commission's strategic plan for 2020 through 2023 is committed to 3 strategic goals and objectives to advance the commission's vision of well-being for all Californians. Cody, can you please bring up the strategic goals slide? Thank you, Cody. At this time, I'd like to make a few announcements. The May 2022 Commission meeting is recorded. The recording of the May 22 Commission meeting is now available on our website. The next Commission meeting will take place on August 25th, and it will be held here in Sacramento.
Recording in progress.
Clearly, we're having technical difficulties, but we're catching up, so we're doing all right. So as I said, the next commission meeting will take place August 25th and will be held in Sacramento. At this time, I would like to invite Toby Ewing to make exciting announcements about the new staff joining the commission team. Toby?
Thank you very much. I want to introduce Melissa Martin, who's in our audience today. She's joined the commission as our new Director of Research and Evaluation. She comes to us with a long career working in the mental health service field, working in performance review with for this, across the state. Melissa's background is just perfect for the work that we're going to be doing around evaluating school mental health, the kinds of services that people receive through full service partnerships, and so we're thrilled to have her join us. It's still very much, she's still in that early honeymoon phase of we're just throwing tons of information at her, but we're really excited to have her join our team. And so if you get a chance to say hello, if you haven't already, we're very proud that Melissa has decided to spend some time in her career with us, and she's going to really help us move this ball forward. I also want to introduce Jeffrey Margolis, who was not able to join us in person today. He is on Zoom. I'm hoping our team maybe can put Jeff on the screen so that he can at least wave. Jeff Margolis joins us as our chief counsel. So we have had Maureen with us, after Phil's departure as our chief counsel, and so Maureen has been keeping the ship afloat. There's Mr. Margolis. Thank you, Jeff. Jeff comes to us with a long history in the legal space, including having served. He worked in the legislature. He's worked in numerous executive branch agencies, including having served as a deputy insurance commissioner for the state of California. So he's fully apprised of the range of legal issues that the commission faces, and it's wonderful to have him as part of our team. And so again, he wasn't able to join us in person today, but over time, we hope you get a chance to say hello to Jeff. So thank you both for joining the commission, and appreciate the chance to make these introductions.
Absolutely. Well, welcome, Melissa. Jeff, I met you last time. Melissa, thank you for introducing yourself this morning, and we're very happy to have you both on the team. So thank you for being here. I wanted to let everyone know that the commission approved 5 innovation projects, each under or exactly for $1 million. We are really excited about these projects. The counties that had approved projects were Modoc, Orange, Tulare, Ventura, and Yolo. Each had a robust community review. Cody, I would ask you now that you please share the slide reflecting those approvals. The documents are included in your packets and can also be found on our website under materials. We're going to get that slide up just so we can take a look at that. There they are. So there's a brief synopsis of what those projects were. So thank you, Cody. So at this point, I would like to invite our fellow commissioners to share updates. So we are going to have Vice Chair Alvarez, if you could please provide an update on the Cultural and Linguistic Competency Committee. And then we will have Commissioner Danovich please provide an update on the Evaluation Committee. And then I will share an update on the Prevention and Early Intervention Committee. So at this time, please, if we could pass it over to Vice Chair Alvarez.
Great. Thank you so much, Chair Madrigal-Weiss. Good morning, everybody. I'm sorry that I'm not able to be there in person, but excited to reconnect with you virtually. The Cultural and Linguistic Competency Committee met about 2 weeks ago on July 14th. We were joined in our meeting by Ruben Cantu from the Prevention Institute and Gustavo Loera and Cindy Beck from California HOSA. As you might remember in a previous update, the CLCC has heard from Ruben. Ruben's with the Prevention Institute. We've heard from him in the past in his capacity as a contractor with the OAC, specifically working on formulating and conceptualizing a framework for moving prevention and innovation further upstream through county behavioral health department and community-based organization partnerships. Ruben returned to provide an update on this work and to share what they are learning as they progress. As a reminder, the Prevention Institute's goal and the promise to the OAC is to build a shared vision by creating common ground between county behavioral health and communities of color, and community advocates, particularly through the lens of COVID's disproportionate impact on communities of color. Through the Prevention Institute's conversations with county stakeholders, with community partners, they have found that there actually are several, as we know, community-county partnerships that are in existence and that are doing great work. We've already spotlighted some of them with the OAC in the past. So recognizing the importance of uplifting these success stories, embracing their advancements, and hopefully replicating what's working and being mindful of the stronger need for communication and messaging, we're trying to work through what are some recommendations about the work ahead. So upcoming project activities will be to do regional dialogues to discuss and refine these potential strategies and ideas for policy change. There'll be more examples that are elevated of these partnerships and what's working. And then in the spring of 2023, so about another year or so, the Prevention Institute and Ruben and his team will provide recommendations on how to sustain long-term systems change to implement and fund these community-based programs on a broader scale. The CLCC specifically will have the opportunity to weigh in on those recommendations and then decide if it, in its capacity as a committee, can also recommend those same priorities to the Commission moving forward. So we then heard from Gustavo Loera and Cindy Beck from California HOSA. For those of you that don't know what Cal HOSA is, it's a student-led organization for middle school, high school, and post-secondary students interested in health and mental health professions. And the idea is to try and address mental health workforce shortages, particularly through outreach to youth from marginalized communities. It was an important discussion that highlighted what sort of pipeline programs exist, another example of one. But I think what was most important in the discussion with CLCC members was they provided important feedback to the organization, especially around the need to focus on additional communities of color. One important flag was the need to really focus on Black communities and the need to really establish a pipeline to bring in more Black professionals in the mental health space. So it was a good discussion and we're looking forward to learning more about that. Looking forward, we have about 4 meetings remaining in this year, and we really want to be intentional about incorporating the committee and public's input as we try to continue to spotlight equity in action. I shared last time that we have a component of our agenda that really focuses on what's working in our mental health field to operationalize equity, and that only gives the OAC more fuel to add to our fire and work around advancing equity. So we've asked that our committee members share any suggestions for speakers, presenters that really can highlight what operationalizing equity means in the community and what are model programs and initiatives. An important flag is whether they are funded by the OAC or not. And additionally, I know Chair Madrigal-Weiss will share more, but we look forward to continuing the dialogue around the Prevention and Early Intervention Committee's report, given that we had an earlier discussion with the CLCC, again, given the close alignment with advancing equity. So our next CLCC meeting is going to be held on August 11th at 3 p.m. And just want to give special thanks to Tom and Deanna and Lester and all the staff that have helped because there's been a lot of activity recently. So thank you.
Thank you, Vice Chair Alvarez. Commissioner Danovich.
Sure. Thank you. I have a very brief update. Our committee has been in transition. We closed out one term of service for our prior committee and reinitiated another term of service. And the major development for us has been the successful recruitment of Melissa, who Toby introduced earlier as the chief of the Research and Evaluation Division. So the next steps for us is really Melissa is helping us to create a framework around conceptualizing the portfolio of work that falls to the Research and Evaluation Division so that we can be strategic in terms of thinking about where to direct our energy, how to support the Commission's work in the research and evaluation space, and what the gaps are that we need to address and fill in a targeted way. So that at a high level is the update. I think staff can provide information about when our next meeting is because I don't have that on hand, but happy to address any questions that folks may have.
Thank you, Commissioner Danovich. Do we have the next date for the meeting?
I don't have that with me, but we'll announce that before the end of the meeting today.
Thank you so much, Toby. I appreciate that. Lastly, I would like to provide a brief overview or a brief update on the PEI subcommittee. We are finalizing the draft of the PEI project report and will make the draft available to the public soon. After the public has a couple of weeks to review, the subcommittee will hold hybrid meetings to hear comments and suggestions for revisions. The subcommittee will hear comments and make needed revisions to the document prior to review by the full commission. So please know that we absolutely do want to hear back from the community, and we will make this a process where, again, this document, it is important that this document belongs to all of us. So more to come on that. We will be sharing those dates as we start to, as we can work them into the calendar. So we will make that, we'll make the announcement on those dates. That will be coming up soon. All right, so we are at, got the date for the research committee. That will be August 25th, and we will post the date and time on the website, so you'll have that information. So we are at our public comment instructions. If anyone is interested in making public comment regarding the announcements or other items, please make those during the public comment time. Commissioners, if you leave the teleconference meeting for any reason and decide to rejoin, please make sure to use the raise hand function so commission staff can make you a co-host again. If you have a comment to provide, please unmute your line and seek recognition when it is convenient. Lastly, if you have any technical questions, please contact Amariani at amariani.martinez@mhsoac.ca.gov. At this time, I will ask Amariani to go over the public comment procedures.
If you would like to comment on an agenda item, please wait until that agenda item starts. You may request to make public comment by clicking the raise hand icon on your computer or the app, or if calling in by phone, push *9. You will be placed in a queue to comment on that agenda item. When it is your turn to comment, the moderator will unmute your line and announce your name or the last 3 digits of your telephone number. When you are unmuted, we are able to hear you. We will do our best to take comments in the order they are received. Please note, once the public comment period for the agenda item starts, we will close the public comment queue. The moderator will insert the word "last comment" next to the commenter's name or number to identify the last public comment, so please make requests to comment as early as possible. Members of the public should be prepared to complete their comments within 3 minutes or less, depending on time constraints. When we have reached the end of your time, our staff will let you know, but we will let you finish your thoughts. We don't mean to cut you off, but we do want to help keep time. We truly appreciate your understanding with this process. Lastly, if there are any members of the public using translation technology, please notify the chair, and at least twice the amount of time will be given to you during the public comment period. A live meeting transcription or closed captioning is available for anyone participating in the meeting. If that option is not currently visible, please activate the closed captioning feature located in the control bar at the top or bottom of your screen. Chair Madrigal-Weiss, I hand it off to you.
Thank you, Amariani. I wanted to clarify something. We just got a correction on the research and evaluation meeting. My apologies. August 25th is the next commission meeting. The next research and evaluation meeting is actually August 17th. So August 17th at 9 a.m. to noon p.m. 9 a.m. to noon p.m., August 17th. So, sorry, Amariani, I was a little thrown when you handed it back to me because I was working on that. So, we are back on schedule. Here we go. Before we move on to the general comment, I'd like to address the Care Court agenda item and the Commission's decision to hear this as an information item. Where? Let me finish what I'm saying. Okay. I know that many of our partners would want the Commission to hear the Care Court presentation and then take a vote on whether the Commission supports or opposes the legislation. However, there are two reasons why we will not be calling for a vote on the item today. First, this legislation is in a process where changes are being considered as advocates have provided valuable feedback. There have already been amendments to the legislation, and we anticipate more to come. As such, we would not want to vote to support or oppose a piece of legislation that may very well change over time. Also, in the limited time we have to discuss this item, it would not be realistic to expect commissioners to come to final conclusions about the bill without hearing from subject matter experts and other public partners. So today we will hear presentations on the Care Court's legislation, which represent the different perspectives on its impact, and we will have a public comment period after commissioner discussion, which will allow those who wish to speak the opportunity to do so. Public dialogue results in better decisions. The methods we employ to help those who need it the most should be carefully considered, and today's discussion will inform that process. With that, I want to welcome everyone again to today's meeting. Recognizing that teleconferences can be very challenging, the plan is to end at approximately 1:45 p.m. or soon thereafter. At this time, I would like to ask Amariani to please take roll.
Commissioner Bontrager, Commissioner Boyd, Commissioner Brown, Commissioner Bunch, Commissioner Carnevale, Commissioner Carrillo, Commissioner Chambers,
Here.
Commissioner Chen,
Present.
Commissioner Cortese, Commissioner Danovich,
Here.
Commissioner Gordon,
Here.
Commissioner Mitchell, Commissioner Roulette,
Here.
Commissioner Tamplin, Vice Chair Alvarez,
Here.
and Chair Madrigal-Weiss.
Here.
Okay, we have a quorum.
Thank you, Amariani. It is now time for general public comment. This time is reserved for comments on items that are not on the agenda. Again, I would like to remind everyone, if you wish to make public comment, click the raise hand button on your computer or the app. Or if calling in by phone, push *9. If you would like to comment on a specific agenda item, please wait until the agenda item starts. Then raise your hand or push *9. Once the public comment period for the agenda item starts, we will close the public comment queue. So please make any request for general public comment now. Please be prepared to complete your comments within 3 minutes or less. If there are any members of the public using translation technology, please let me know and we will make sure that you have sufficient time to make public comments. Amariani, please open the line for general public comment.
Okay, we have 5 raised hands. Matt Gallagher, your line is open. You may go ahead.
Thank you. Good morning, Chair and Commissioners. Matthew Gallagher, Cal Voices, he, him, his. I come before you this morning to express our ongoing opposition to the authority to approve innovation plans under the delegated authority in Rule 2.6 of the MHSA's Rule of Procedures. Specifically, there's been now 5 innovation plans approved by the executive director through the chair of the commission without a public hearing, without a vote of the commissioners, and we find that to be problematic at least. When we look at the plain language of the MHSA, we see no authority for the chair to delegate this authority to the executive director. More importantly, when we look at the innovation regulations, specifically section 3905, the procedure outlined in the rules of procedure 2.6 is not even consistent with the regulations. So that raises several questions. One, where is the statutory authority in the MHSA for Rule 2.6 to even be legally feasible? And second, why is Rule 2.6 inconsistent with the regulations in the CCRs for innovation plans? From the looks of things, it appears to be a form of underground rulemaking prohibited by the Office of Administrative Law and California's Administrative Procedure Act. So I am curious, and I know that it won't be answered today, but maybe it'll be answered sometime in the future. What is the legal justification from the statute, from the regulations to justify Rule 2.6? Is a deviation from historical norms for innovation plans, and at no time in history has this ever been allowed or permitted. And I know from speaking with the drafters of the MHSA and reviewing the legislative history for the MHSA, it was never anticipated that the commission would be delegating its duties to the chair and the commissioner and the executive director, I should say, for the approval of innovation plans. And so for those reasons, I remain in opposition to that action. Thank you.
Thank you, Matt.
Next, we have Raphael. Your line is open. You may go ahead.
Okay. Good morning, everyone. Thank you, Mariani and Chair Madrigal-Wright-Weiss. I wanted to also just quickly send a warm welcome to Melissa and Jeff. For starting, can't wait to hear about your work. My name is Raphael. I work for Safe Passages. We're a behavioral health services provider in Alameda County. I wanted to say that in reviewing the materials packet that was sent out for this meeting, on page 2, I noticed that there's something about agenda items maybe moving around for this meeting and maybe other meetings moving forward. And I wanted to ask the commission to maybe give us more guidance on how we can use that information to help community members plan in attending and making sure that they can speak to the agenda items that they're most interested in. Thank you.
Thank you.
Adia, your line is open. You may go ahead.
Hi, good morning, everyone. My name is Adia Fadai. I am 19 years old and a rising junior in university and a resident of Los Angeles, California. So a little on the younger side here today, but still excited just to bring up, something that I've been thinking of recently. I've been a peer mental health advocate since I was around 14 years old through working with different mental health organizations and specifically as an advocate with the organization Bring Change to Mind, which is in high schools nationwide, but also specifically all around California. So Bring Change to Mind is a peer-led high school program centered on mental health awareness and prevention programs. I spent a portion of my time in high school with Bring Change to Mind as a peer advocate, a club president, and an advisory board member, and now I'm an intern with the organization. And so, especially as the US Surgeon General has really accentuated our necessity of mental health resources that are peer-led amidst this youth mental health crisis, I'm interested in hearing how the commission is leading and investing into specifically peer-led and prevention programs in this fiscal year. Through my time in the mental health space, I have really noted the deep need for funding for these critical programs. And I also feel as though the youth nonprofit sector is really detached from state agencies. I feel grateful for the work being done, and I'm really appreciative that we're able to make these comments, but I also hope to hear more about investment and state support for these crucial and specifically peer-led youth resources.
Thank you.
Okay, next we have Stacy. Your line is open. You may go ahead.
Good morning, Commissioners. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. First, I would like to support Matt Gallagher's comment regarding the approval of county innovation plans. This is one of the most important things that the OAC does, so it should be more public and transparent. I would also like to support the comments of Rafael Enriquez. I noticed that you have a new format for the commission meeting agenda. It's very nice. I also noticed that you put the new advisory language at the beginning of this agenda. One of the items is, again, what Rafael referred to, that the commission reserves the right to take action on any agenda item as it deems necessary, whether or not it is labeled as an action item or an informational item. And two, items may be considered in any order at the discretion of the chair. Whether or not these are allowed by the Bagley-Keene Act, I believe these are not conducive to participation by the public. It's often difficult for the community stakeholders to stay for your entire meeting, especially if you have to go back to having meetings in person that last for the entire day as they did pre-pandemic. In the past, public members have planned to attend sometimes only for action items, but now they must attend if any of the items are of interest or concern to them. Moreover, if an item is allowed to be moved to the back of the agenda, they would really have to be present for the entire meeting. Again, even if this is legal, it is not good practice in terms of public participation. I hope you go back to your former practices of sticking to the order that items are listed on the agenda items and allowing a vote on items that are listed as action items on the agenda. That being said, I still don't understand why you did not label the care court item as an action item. There is almost no point in taking a position at your next meeting on August 25th. The legislative session this year ends on August 31st. If the bill is still alive, it would have gone through all the committees and it would be most difficult to affect the outcome at that point. All bills could be amended throughout the process, and using that reasoning, the OAC should not take a position on any bill. You could take a position, and if the bill is significantly amended, you could change your position. The care court issue may very well be the most significant issue for the behavioral health community this year, and I am puzzled why you do not want to take a position on it. The measure directly affects the MHSA. It is inconceivable to me that you did not put this on the agenda that you put it on the agenda as an informational item. But the issue is
Thank
not
you, Stacy. Your time
should,
is up. If you could wrap up your comment.
okay.
Thank you.
The issue is not that you should be able to vote on any item, even though they are labeled informational. The issue is that you should have labeled the care court item an action item. Thank you.
Thank you, Stacy. Thank you to all members of the public for your comments. The commission, I'm sorry. I'm sorry.
We have one more.
Sorry, thank you.
And then the number ending in 718, your line is open. You may go ahead.
Hi, this is Steve Leone, and I've been having trouble with dropped calls, so I hope nothing drops here. I'm speaking about legislation also, but not care court, because the only legislation on the agenda today is care court, and I wanted to speak to AB 2242. And it greatly unnerves me. If you look at it, they talk about, having MHSA dollars to fund acute and subacute care for someone on a conservatorship for up to a year, which doesn't seem to me like part of the mission of the MHSA. And I mean, even AOT is, you could say that, well, you're trying to keep people from other things, so that's but here you're just like saying people are locked up and this is going to pay for it. And I would like to make the point that it may not even be needed because currently DHCS is working with the federal government to have a waiver of the IMD exclusion for 30 days, which would allow Medi-Cal to pay for what it couldn't pay for before. And I support that. right now it's very uneven between counties. And at the same time, this is something that we don't need to use MHSA dollars for. I mean, there's a process going on whereby a mandate by the federal government that you must expand the capacity in the community in order to qualify for this waiver of the IND exclusion. And that's an ongoing process. And this bill simply says, we're going to mandate up to a whole year worth of acute and subacute, treatment. And it just, maybe guys are doing this offline and you've spoken up about this someplace, but I've never heard you say anything about it. It seems to me like at the moment, this is a direct loss of the idea of the MHSA, which was based on voluntary services. So thank you.
Thank you, Steve.
And that was our last public comment.
Thank you, Amariani. Good morning. The Commission will consider approval of the minutes from the May 26, 2022 teleconference meeting. At this time, members of the public may request to make a public comment on item number 4 by clicking the raise hand button on your computer or the app, or if calling in by phone, push *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. Commissioners, are there any questions or comments? On the virtual world?
No comments either.
Thank you. Are there any public comments? Please raise your hand now as the queue will be closing.
There are no public comments at this time.
Okay. Then, Commissioners, do I have a motion? Thank you.
Second.
Thank you. Any additional questions or comments from commissioners?
There's none virtually either.
Thank you, Mariani. Then I would ask that you please take roll.
Okay. Commissioner Bontrager?
Aye.
Commissioner Boyd? Commissioner Brown? Commissioner Bunch?
Aye.
Commissioner Carnevale? Commissioner Carrillo? Commissioner Chambers? Commissioner Chen? Commissioner Cortese? Commissioner Danovich?
Aye.
Commissioner Gordon?
Aye.
Commissioner Mitchell? Commissioner Roulette?
Aye.
Commissioner Tamplin? Vice Chair Alvarez? And Chair Madrigal-Weiss?
Aye.
Commissioner Chen? There is not a quorum at this moment for this item.
Just so let's hold over the vote.
Okay, we'll
Right.
hold the
This
vote.
wasn't the roll for the quorum.
Oh, sorry.
This was a vote on the adopting the minutes.
Yes,
Okay.
yes.
So let's work to connect with Commissioner Chen and Commissioner Alvarez, and we can come back to finish the vote on this at a later point.
Okay, we will
Thank
return
you.
to this item.
Thank you. Now moving to item 5, the commission will hear an update on SB 1338, Care Court legislation. We will hear from Stephanie Welch, who is the Deputy Director of Behavioral Health for the California Health and Human Services Agency, and Karis Merrick, who is the Co-Director of the Mental Health Strategic Impact Initiative. Thank you both for being here today. Members of the public may request to make a public comment on item 5 by clicking the raise hand button on your computer or the app, or by pressing *9 on your phone. First, we will hear from Stephanie and then Karis. Please go ahead, Stephanie. You can begin. Thank you.
Great. Well, thank you. I'm happy to be here. I think I've come once before, maybe in this position a while ago, so nice to be back. I think I'll go ahead and start with the slide deck. I will probably try to go through these pretty quickly. I know you guys really want to use this as an opportunity to ask questions. I will do the disclaimer that there are many people who are working on this, and I will do my best to answer your questions. And if I cannot, I will certainly get you responses in writing. Next slide. So I think I really wanted to start by kind of talking a little bit about some of the landscape and some of the other things that we're doing in the behavioral health space as part of this administration, because Care Court is one of kind of a whole orchestra of different things that are going on to transform the behavioral health system. And so I think it's important to kind of ground us in some of those activities. So I will be brief about them. I tried to make it very brief. So I think, and I think I talked about this the first time I came to talk to you guys. I mean, we are so, frankly, blessed to have an administration and a legislature that care deeply about this particular topic and really want to invest and transform our behavioral health care system. And we've had a number of very large initiatives over the last 3 years in order to achieve that. And I think what we've learned in trying to accomplish that, for me, in being in this position for just about 2 years, is how incredibly challenged we are with our lack of capacity, and that we have significant fragmentation in our system. And that's really driven by decades of stigma where behavioral health care, both most notably substance use disorder services, was really not seen as part of the healthcare system, and it wasn't invested in as such. And so we really have a lot of work to do, as you guys are well aware, in order to build out that capacity. And so much of the investments that have been made in the recent few years have been really focused on building out capacity. So next slide. So our Department of Healthcare Services released a behavioral health needs assessment at the beginning of the year. Oh, thank you. I'll speak more into the mic. And there were a couple of things that really stood out. And while it was not comprehensive, it wasn't all the data, it was a lot of data that did tell us, or at least confirm for us, many of the things that I think we know. I think many of the things that you guys have tackled as issues as well. And first, there was a very scattered array of crisis services that the state itself, depending on where you were, you'd have a very different experience if you needed to use crisis services. What was constant across the entire state was that we needed more community-based living options. Everything from long-term residential care for people who have very serious conditions to short-term crisis care. And also just everything in between, frankly. Permanent supportive housing, I could go on, but there just were not choices. There's just not options for folks. Treatment options for children and youth in particular, and in particular substance use disorders, were significantly sparse, really helping to make it clear to us that our focus on children and youth is much, much needed. We also were identified that there are very different experiences, as well as in terms of quality and access, that highlight how much we need to advance equity in order to address disparities. And then lastly, if you're someone living with a serious mental health condition or substance use disorder, it was far more likely that you were going to be experiencing poverty and that you would have challenges getting housing, economic opportunities, that your physical health could be compromised, and unfortunately, you are more likely to be justice involved. These are all things that you guys are well aware of that kind of plague our under-resourced system. Next slide. So the next, I think, 2 or 3 slides really just kind of summarize some of the kind of major initiatives that we have to transform behavioral health in the course of the last couple of years. I'm sure each of these items probably warrants an entire day presentation, so I'm going to be very brief. I think the first kind of really innovative thing, I think we actually started this prior to the pandemic, but it was our CALAIM initiative, California Advancing and Innovating Medi-Cal. I think for behavioral health, it's transformative in a variety of ways. One is really trying to create a seamless transition between the mild to moderate system and the specialty system with a no wrong door approach, but also really things like payment reform, helping us really try to get to parity with other physical health conditions, and to have a system where people are, the providers are resourced in the way that they need to be in order to deliver the care and how much that care cost. And also to really focus on outcomes, frankly, instead of paperwork and filling things out and getting reimbursements, really focusing on did the service itself help the person, and what were the outcomes. The Children and Youth Initiative, I know you guys have spent some time talking about that. I think it just really doubles down on the fact that most people who may experience a mental health condition in their lifetime will have signs and symptoms and needs when they're young people. And if we can get in there and provide them the kinds of services that they want and that they need, and have it be accessible, then hopefully we will change the trajectory of their lifespan, of their life. Of course, we also, in this year's budget that just closed, were able to secure another nearly $200 million for a youth suicide prevention and behavioral health campaign. And that just is just recognizing that suicide rates are rising amongst young people, particularly black and brown boys, and young girls under the age of 24. So we have a fentanyl crisis. I don't think I need to tell anyone about that. And so that also is an issue that's really impacting young people as well. We're also investing in preventing and addressing crisis. Under your wisdom and leadership, we were able to establish an Office of Suicide Prevention so that we really have a locus of policy making on this topic. At agency, we're doing some care continuum planning. DHCS is continuing to invest in CalHOPE and kind of think about what CalHOPE's future is, which is a crisis counseling and training program. And then also we invested in our California peer-run warm line and have been preparing to roll out the 988 implementation. Next slide. Other core issues, I mentioned a little bit about the work that we're doing to address the opioid crisis. I'm not going to go into detail there, but I think what's important about that bullet point is to recognize that there are emerging evidence-based practices in this space, and we really want to take them statewide. So really excited about our contingency management pilot. We also were approved for $1.5 billion for behavioral health bridge housing for people experiencing imminent risk of homelessness or people experiencing homelessness. This money goes directly to county behavioral health over the course of the next 5 years to do a variety of things, whatever it takes, frankly, locally, in order to provide and get access to necessary housing for behavioral health clients in the specialty system. And then the last bullet here, this adds to the $800 million we were awarded last year as part of the KIDS initiative, another $1 billion to invest in our workforce. the vast majority of the investments in that space are for people who work in the behavioral health system. Next slide. More infrastructure pieces here. This was last year, but it warrants a discussion. We're in the middle of rolling it out. We're about halfway through our RFP rounds. So $3 billion to build out the community-based care system, including adult residential placements that's managed by our Community Care Expansion Program, and then our Behavioral Health Continuum Infrastructure Program, which is being managed by DHCS. So really the idea is in that assessment, as I mentioned, there just are tremendous gaps in terms of facilities as well as long-term community-based alternatives for a variety of different housing settings. And this is a program that can invest in trying to address some of those issues. We continue to be committed to finding alternatives to for felony ISTs. We'll talk a little bit about misdemeanor ISTs as part of Care Court, but again, we truly believe that this is a population that can be served in the community, and there is not a need for them to go to the state hospitals, and most certainly not a need for them to continue to be prosecuted criminally. And so we continue to invest in that. And lastly, and what we'll spend today talking about, is Care Court. And Care Court provides administrative resources to the Department of Healthcare Services, Agency for Planning and Oversight, and the Judicial Branch for the implementation of the role that they will play on the civil side. So next slide. We'll get into the meat of it now. Next slide. Sorry, next slide. I'm used to having my own slides and go right through here. So the Care Court, or the Community Assisted Empowerment and Recovery Act, we envisioned it as a new pathway. And I say pathway because it's not a program itself. It's a pathway. It's a means to an end. And I think that we're trying to be better about explaining it in that sense. But at the core of it, it really was, we had spent so much time in the last few years trying to do things like de-incarcerate our jails, work on the IST crisis, and of course, you guys are well aware, and there's been a topic for the last 10 years, whether it be in the legislature or in our behavioral health community, around, does the LPS work? Should we do something around conservatorships? What is it that we should do? And what we said is, we really want to prevent conservatorships, and we want to prevent incarceration. We've been working around the edges, so to speak. And so this is the administration's design, with input from many of you, and it's still frankly in the process of being designed, and I'll get to that in a little bit. But things that I think are significantly different about it, or what we think is unique, is that it really is about both the system being held accountable as well as the participant. Everything that we have designed right now in this space is really, the onus is all on the individual who's experiencing a mental health challenge. And we felt that it was time to create some accountability on the systems that are charged and responsible with providing high quality care to this population. So I think the other thing I want to say, and I'll talk a lot about it probably today, is that Care Court is not for everybody. It's very specifically only for a small subset of the population with really, really high needs. And so I want to be clear that Care Court was not designed to address homelessness, and Care Court was not designed to be the sole solution to solve our challenges with people who have very, very serious mental illness who are living on our streets. Next slide. So I think a lot of people have asked us in the past, why didn't we just work on changing LPS conservatorship, or why didn't we just try to make changes in Laura's Law, our current assisted outpatient program, which uses a civil process to enroll people into the AOT program. And I think there are a couple of things that were really important in the design to do things differently. For one, and as you'll see throughout this, we didn't feel like there was any need to change LPS. Again, the goal of Care Court is not to conserve people. So again, we didn't feel, we were concerned that conservatorship should always be a last resort. And for many people, unfortunately, it is something that is necessary. But it can lead to more custodial settings for individuals and more long-term involuntary medication usage. So we felt that we really wanted to try to prevent conservatorships for a particular population. And then also, I think in terms specifically of being different than Laura's Law or our current AOT model here in California, is that we wanted more people to be able to petition the court to investigate whether somebody was a credible candidate for care court. Laura's Law, the petitions are all managed through the County Behavioral Health Department, and we felt that that might be a deterrent from more people who are engaging with these individuals and have concerns and would want to submit a petition. We can go to the next slide. So some of these next, like the next 5 slides, have a lot of content, and I did that because it is really a very complicated legal process. And I also think that it's changed so much. We've probably had, I think, 4 rounds of amendments, and I want to make sure that we're accurately sharing with you guys exactly what the process is. And a lot of people have a lot of questions about literally the process. So here is from the actual text. This is the criteria to be a care respondent. So the person has to be 18 years or older. The person has to be experiencing severe mental illness and have a diagnosis of schizophrenia spectrum or other psychotic disorder. The person must not be clinically stabilized in ongoing treatment. That care court would be the least restrictive alternative. So these are people who are hospitalized or at high risk of hospitalization. That the person would benefit from care. And then the last 2, I know they're probably hard to see for people in the audience, but that the person meets one of these particular criteria. And so the person is either unlikely to survive safely in the community without supervision, or the person is in need of services and supports in order to prevent a relapse that would result in meeting the threshold for a 5150. Next slide. So pathways, it gets kind of confusing, so I'm going to walk folks through it. The first step in the care pathway is for a petition to be filed. There is listed the types of people who can submit a petition. A petition is then reviewed by the court. If there's no evidence, and I don't have a lot of the legal language in these slides, but if there is not a preponderance of evidence that the person meets the criteria, then it's dismissed. There's no hearing, none of that nature. This is a new piece that we put in, so I'm going to take some time to explain it. The court, if there is evidence that the person may, meet the criteria, then the court orders the county to investigate and file a report. That's a 21-day process. In many ways, we're seeing this as a process in which we're hopeful that in the feedback we got from many of the stakeholders, they really wanted us to create a process in which any petition that is submitted that has credibility, that the person is offered voluntary services. And that's basically what this process is. And we require that the county submit something to the court so that there's some accountability to make sure that this person was reached out to. I think this could be hopefully a good opportunity for those who are really needing and wanting care, that they are offered that care. And if the engagement process is working, but there's still more time that's needed, an additional 30 days can be granted to continue to support enrolling that individual in services. Next slide. So petition to initial hearing. The court, once the county submits the report of how the engagement process went, the court reviews the report within 5 days. If the court determines that the voluntary engagement was effective, that the individual has enrolled in behavioral health treatment or is working with the treatment team, then the order is dismissed. If the court determines that the respondent meets the criteria but did not choose to engage with the county during that engagement phase, then a hearing will be set within 14 days. And the court will provide notice of the hearing to the petitioners and others. At that initial hearing, the court determines whether the respondent meets the care criteria. And I'm not going through all the details, but there's evidence that's shared, et cetera. And again, at this point, I do believe that I should know this, but I don't remember. I can double check, but I do think that at this point, even at the initial hearing, the individual who is the respondent, the person who the petition is placed upon, does not need to show in court. So the court orders the county behavioral health agency at that point to work with the respondent and to develop, and the care supporter, if the person has chosen to have one, to engage in behavioral health treatment. And the next step is called a case management hearing. Next slide. If the court finds that all the parties have come to an agreement that this is basically voluntary engagement step number 2, maybe the engagement wasn't effective or the person wasn't interested in that first 21 plus 30-day process, here's another process. And if it's effective, there's a note of that. If not, then the court will order a clinical evaluation of the respondent. And that has to be conducted by a licensed behavioral health professional, and there's another hearing within 14 days. Next slide. So from the clinical evaluation to the care plan, if at the clinical evaluation hearing, I told you it was going to get real technical, the court finds that the respondent meets the care criteria, the court will order the development of a care plan. If not, the court dismisses the petition. So I think if we're tracking, we have the off-ramp number 1, which is at the 20 days and 30 days. Then there is the off-ramp for a care agreement, so there's no court-ordered care plan. And I'm losing slight track of the days, but that could be anywhere between another 14 to 30 plus days. And now we're at the process where the court has issued an order to develop a care plan. And so the care plan has to be developed within 14 days. There are some exceptions, some extensions that can be granted for various reasons. And it is to be a process that is done together and collaborative. And then the report is shared back with the court, and the court may issue any orders necessary to support the respondent accessing the appropriate services and supports that are in the care plan. And the court has the authority to prioritize services and supports for care recipients. The issuance of the order of approving a care plan begins the up to 1-year cycle of care court, the time of the actual court care plan. Next slide. So I know that's a lot. It's complicated. I think right now we're trying to actually work on a graphic, like an infograph that would help kind of make it easier to understand the various different pathways, so to speak, in care. So coming towards the end of the year process, there will be a hearing, and respondents can graduate. The voluntary graduation plan is simply what we would call like maybe a transition plan. It may, if the respondent wants it, to include a psychiatric advance directive. But the idea is that this is an individual who is transitioning to ongoing community-based care, and this gives us an opportunity to really develop a plan by the individual in care court to transition safely and hopefully thrive in the community. And I kind of put these 2 bullets in the wrong slide, but the last 2 just simply, this belongs more in the referral pathway, but if you are a judge, you can refer folks who are in an AOT program or who have pending conservatorship proceedings, but you would like to prevent conservatorship, the court can refer someone to care. Also, if you are an individual who is in the middle of misdemeanor criminal proceedings, the court has the authority to refer someone to care. So in essence, dropping those criminal proceedings. Next slide. So accountability. We'll go to the next slide. As I mentioned at the beginning, something that is different about Care Court is that there's accountability both on the individual as well as the governmental systems that are charged with providing services. So for an individual, at any point in the proceedings, if someone is not participating, they never show up to court, they don't want to be, in the program, it is up to the judge who may completely terminate the respondent's participation in the care program. That's it. And then the court may, the other thing that the court may do if the person is not safe, as I mentioned before, we did not do anything in this proposal to make changes to the LPS Act, but the court, as it always does, has the ability to utilize existing authority to ensure someone's safety if someone is a danger to themselves, or all the other pieces that go into the criteria for 5150. And so that's, if the court does have to do that, we made this additional change that they would at least notify the public conservator and guardian. And then also, this is something that we've been trying to explain it in a better way, but if somebody does not or is not successful in Care Court, that piece of information can be used as evidence if that there's no suitable community alternative to treat the individual, and that we updated this slightly. That is something that is available, but only for up to 6 months, which is not reflected in that slide. I apologize, but it is reflected in the June 30th amendments, meaning just because this happened to you, you can't use that after 6 months as a factual presumption. Next slide. So government accountability. So the court can fine a county or the local government entity for not complying with care. The fines will be used to establish the CARE Act Accountability Fund. This is a fund that will be at the Department of Healthcare Services, and those funds have to be used to support local government efforts to serve this specific target population. So individuals who have schizophrenia or other psychotic disorders, and they are experiencing or at risk of homelessness, criminal justice involvement, hospitalization, or conservatorship. Next slide. So we have 2 elements around reporting and evaluation, and really got a lot of just really excellent feedback from many different stakeholders in designing this. So first is the ongoing reporting. So this will be developed in consultation with a variety of experts, which you can read there. And there is an annual CARE Act report that has to be submitted. And the June 10th amendments really go into a significant detail about all the data elements that will be collected. And they're right there on that slide. So again, DHCS will collect and then provide back information in an annual report with stratified data by age, sex, race, ethnicity, languages spoken, disabilities, sexual orientation, gender identity, health care coverage, and the county of which the individual resides. And then, of course, only to the extent that that is statistically relevant data, but also health protected personal information, because we have small counties as well. So, but again, I think that this is, we'll, I'm sure, talk about this today, but it's really critical that we're collecting this information in order to ensure that it's being implemented in a way that is appropriate. I'll talk about that in a moment. Next slide. There also will be an independent research-based evaluation of the CARE Act. Similar things will be looked at, but it will be specifically looking at, in many ways, whether or not this is leading to disparities in reduction. my God, a reduction in disparities, excuse me, talking too much. And then we will, that evaluation will be submitted to the legislature, and it's due, a preliminary is due in 3 years after implementation, and 5 years is the final report. Next slide. We're almost done here, guys. So getting to the good stuff, we have received a lot of feedback. This really just highlights many of the things that you guys saw in your packet with the letters that have been from many of the different organizations and advocates. So again, opportunities for early services and opportunities for engagement, we have attempted to do that as best as we have tried, that we would offer and make sure that voluntary services would be offered to individuals who a petition was filed. Really have learned a lot about the supporter role and how we should be thinking about ensuring that supportive decision-making is something that we do kind of across our whole system. And this might be really an opportunity to explore how to do that. And we're really still and very interested in all of the support to think through how best to do this and have it be an additive role. But also heard from people how incredibly important it's going to be to have peers as part of the care team. The importance of ensuring that trauma-informed policies and practices, as well as addressing racial bias, is part of the care court process. We're trying to track any, I don't know how else to put this, but we're trying to use the reporting and the evaluation to track concerns, which I think are very extremely valid concerns, that certain groups of people, particularly Black men, will be overrepresented in care court because of the number of people who are homeless and just misdiagnosis of schizophrenia in this population. So, and I'm sure we will talk a little bit more about that. And I think we acknowledge that it is a concern of ours as well. We heard a lot about the fact that there just aren't enough housing resources to meet the needs of folks right now. And while we have had all of the investments I talked a little bit about at the top of the hour, they haven't really materialized yet, and thus real concern over having the capacity to serve this population. And I didn't have it on any of my slides, but we estimate statewide that this is about 7,000 to 12,000 people. We had concerns on, of course, like all around, a whole 360 of concerns. So we had a number of people who were not happy and felt that the criteria was far too narrow and that we were not addressing other really high need, high vulnerable populations, most notably the population of individuals who are unfortunately unhoused and suffering from really, really serious substance use disorders. Those are not individuals who would meet the criteria for care court. Concern over the implementation timeline in general. We're just doing this too fast. Again, there's not the capacity, et cetera, et cetera. So these are all things that we really did try to find ways to address in amendments over the course of the last several months. Next slide. So I'll go to the next slide. I say this, and then this is me editing, and I apologize because I gave you guys the wrong version of my PowerPoint. But these are busy times, and so you do see a strike through there, which is accurate. The supporter role is housed at DHCS, and it can be family, friends, and peers. I'm not totally certain why that was striked out, so I apologize, but that is an accurate, that is accurate. I think we'll talk a little bit about how we've changed the supporter role. But first and foremost, some of the key changes, as I mentioned before, the court directs county behavioral health to have an engagement process so that we can ensure that voluntary services are always offered. Right now, there's a two-phase county implementation process. We're doing a lot. We have lots of conversations with the counties to talk about what makes the most sense. DHCS is going to be the entity that will be providing training and technical assistance. Our agency is going to be responsible with initial implementation coordination. for the first 3 to 5 years. And this was a request of the legislature, this is a significant policy change. It requires significant coordination and collaboration with the judicial branch, and we feel like we can help support that coordination. Another big change was moving to legal aid representation, and no longer assigning the individual or requiring that a court assign the individual public defender. I think this is also an area where people have very different opinions on whether or not that was a better way to go or not. I think for us, we felt that legal aid is an entity that does a tremendous amount of advocacy, and that they would be a tremendous advocate for the respondent. We create the CARE Act Accountability Fund, which I described earlier. We also included a significant both independent evaluation as well as an annual report to the legislature. And we've required that trauma-informed care practices and elimination of racial bias training is required of both the court partners as well as our county behavioral health implementation partners. Next slide. Okay, FAQs. I'm just going to go over really quickly some of the main questions that we get. So one of the main ones is, why doesn't CARE include all behavioral health conditions? Why are we just narrowing it to this particular small subset of people who are experiencing mental health conditions? We felt it was really strongly for CARE to be focused on a particular diagnosis that was the most that is both severely impairing but also highly responsive to treatment. Highly responsive to treatment. What we've learned in the last 10 to 20 years is that that we can provide better evidence-based treatment to people who are experiencing schizophrenia and psychotic spectrum disorders. And this is basically giving a treatment package to an individual who needs a significant amount of care, and it's really pairing high needs with a highly resourced approach. Broader behavioral health redesign is what we're in the middle of doing. I think so many of the issues, I mean, if I get to the heart of what I've at least experienced in the last 6 months, is that this particular conversation has led to a conversation about making improvements in every aspect of our behavioral health system. Probably most notably our crisis care system, which Care Court is going to touch on, but we have a ton of work to do in terms of redesigning how, basically, the bottom line is, how do people access care? And how people access care right now is in crisis, because that's all we got. So we really need to double down and focus on the other things that I mentioned earlier so that we can improve access to our system. But again, that's not what Care Court is not trying to solve for that. Is not trying to create broad access or create alternatives to crisis services. So I just want to be clear about that. It really is specifically targeting individuals who are living with untreated schizophrenia and other psychotic disorders who are impaired to the level where we feel that they're at great risk of conservatorship. Next slide. Does Care Court guarantee housing? So the slide there really just says that that Care Court and having a housing solution is part of the care plan. But what I'm going to share with you that's not on those slides is that the judge, and this being in the civil court, and the judge having the ability to give court orders and having the ability to prioritize care for these clients. We do not have a right to housing in this state, and Care Court's not going to solve that policy issue. But we do have the ability through Care Court and through our judicial branch for the court to order these particular individuals to be prioritized for housing. And we're working on some other things in the next round of amendments, but I think we really do understand how challenging it is. I live in Sacramento. I see it every day. I see it growing every day. At the same time, if we are laser focused on trying to solve the issue and to put people with the highest of needs in what we have available, then we think that we can do this. And hopefully the bridge housing money will help. But we also have the $12 billion investments that have been made in preventing and ending homelessness. And I know our agency has really focused, my colleague who's not here today, who's really focused on homeless and housing policy, really focused on ensuring that those investments do a better job reaching people with serious mental illness, which I know there have been some criticisms of those resources not necessarily reaching high-risk, high-vulnerable people with serious mental illness because there haven't been the wraparound services to go with the housing. And so we really want to explore how to make improvements in that space. Next slide. So why the courts? I think it's a good question. I think we learned a lot. I certainly recognize that the courts, I don't want to say the administration recognizes that the courts, doesn't matter if they're civil versus criminal, is an extremely potentially really traumatizing or frankly re-traumatizing experience for individuals, because the court, no one likes to go to court. No one likes to, maybe there are people who like to be on jury duty or things like that, but generally speaking, it can be a very, very intimidating process. And so we don't want that to be the case. Again, we want to keep people out of the criminal court system and out of conservatorship. And I think something I hear the secretary say all the time, and I hear many of the judges that we've been working with say all the time, I would much prefer to have somebody in a civil court than a criminal court. And right now, there's a lot of people in their courts who are suffering from untreated mental illness. So that is one of the reasons why. The court also allows us, to be frank, the ability to hold county government accountable to prioritize this population. So that is a necessity of the court being involved. We are very interested in working with everyone to try to manage the involvement of the court. Certainly, I've heard a lot about you can go to one county or you can have one court, or judges are very different, and I do think that this is going to be work that we need to do. But I have met in my time so many passionate judges and people who work in the court system who would love nothing more than to make sure that we no longer have to have things like criminal mental health court, because we are diverting people and we are treating people before they are incarcerated. Next slide. Does care perpetuate stigma? As I mentioned before, there are well-documented inequities in clinical diagnosis and inequities in our court system. They're well-documented. We acknowledge these realities, and I think we are attempting as best as we can to put them in the design of our program and to hold ourselves accountable by collecting the data to see if this is something that is being perpetuated with care. I also think that we feel like we can really, since it's in our foreknowledge, that we can work towards not just addressing this in care court, but really thinking about how do we address this as it is a problem across our system. This isn't just a problem that is going to be experienced at care court. It's a systemic problem across our behavioral health system, that there is racial bias in the delivery of behavioral health, period. So I think we really want to explore with our stakeholders how could we use this as an opportunity to really more comprehensively tackle the problem. And that's, you can read the rest. Next slide. So how is self-determination supported in the care court model? It is important to us, and I can recognize that people are going to disagree with this particular statement, but we're trying to target people who are unfortunately may be incarcerated or conserved, of which there is no self-determination in your recovery. And so we wanted to work with legal aid. We felt legal aid was a good choice because we felt that they would be a counselor and a champion and an advocate for the client. We also created the Care Supporter, and we're really interested in all the support that we can get from our stakeholders to design that in a way that's added value, as I mentioned before. And again, the care plan ensures that the services and supports are those that are picked by the individual and is an individualized plan. Next slide. I think I'm done. Yeah. And I'm sorry, I don't really have any idea what the structure is, or I just took the liberty to have a very detailed presentation. I hope that that's okay. And can take any questions or...
Well, thank you so much for that presentation. We are going to ask Ms. Merrick to present as well.
Okay.
And Ms. Merrick, I apologize. I got your title wrong initially, so I just want to clarify that Ms. Karis Merrick is the Vice President of Partnerships at Inseparable. Did I get it right this time? Thank you so much. And so with that, I'm going to ask you to please present. And again, we're here to just soak in the information. So please.
I don't need my slides yet, but thank you very much. And the switch is new, so no problem that it's reading the old thing versus the new thing. So first of all, thank you for inviting me to come here and speak. And for people who may not know who I am, I'm located in Los Angeles County. I've been a resident there on and off for about 20 years. I worked for the federal government for 5 years at the Substance Abuse and Mental Health Services Administration. So I was 5 years outside of LA, and then came back to LA to be the chief of peer and allied services for LA County Department of Mental Health. I'm also a person with lived experience of a mental health condition, given a diagnosis of schizophrenia, and I've touched probably every system known to mankind that many of us do touch. So that can hopefully ground you a little bit. And I'll be speaking on behalf of sort of what I'm hearing in the broader field. So a lot of my work is on the personal side as well as on the professional side, partnering with and being a part of the larger movements, if you will, and there are several. So it's both, with family members, people with lived experience, providers, et cetera. So, but right now, I think I do want to go ahead and start with my slide deck, if you don't mind. And I'm sorry you all didn't get it. I was on the plane and I sent it, and it got stuck on the plane with me.
Somewhere up there.
Yeah, so hopefully somebody has it.
Thank you. We can get copies afterwards.
Okay.
Cody, if we could get the slides up. Thank you.
So I want to start by showing you a picture of BB Moore Campbell, because it is BB Moore Campbell Minority Mental Health Awareness Month. Many people call it BIPOC Mental Health Awareness Month. It is BB Moore Campbell Minority Mental Health Awareness Month. Please do say her name. She's an African-American woman. She's no longer living, who fought for the rights for people with mental health conditions because she had a family member who struggled with a mental health condition at the time. She's a founder, one of the founders of NAMI Urban LA. And as such, after her passing from brain cancer, I think it was about 11 years ago or so, there's a congressional act that dedicates July as BB Moore Campbell Minority Mental Health Month. I don't mind the term BIPOC at all, but I do mind the fact that we're erasing the name of a Black woman who has a month named after her to recognize the importance of minority mental health. Thanks. And the other reason, and I'm really starting here for another reason, I probably should be a little bit more transparent about it. I was going to get to it, but I'll go ahead and do it now. Is that when the care court conversations came up, I'm a very inquisitive and curious person. So I always like to look at the data. I like to understand how data kind of works, especially as I dovetail it against people's various experiences of the systems. I'm not going to say one system because I think there are many, but and one of the first things I noticed, of course, were, thank you, Stephanie, for bringing it up, the disparities for communities of color, particularly disparities for the Black community, as we're talking about the population of people who are unhoused compared to the size of the population in California, and also people, Black males and Blacks in general, and being overdiagnosed with schizophrenia. When I brought this up and said we have to have this as part of the conversation, it cannot be separate from the conversation, quite frankly, I was told by our state consumer network, no, we don't talk about Black people, we're going to talk about peers. This is a peer thing. I don't mean to be rude, but I'm a Black peer. There are many Black peers, and I don't know how this couldn't be a Black issue and a peer issue, but somehow it was determined they were not going to talk about Black folk. It's okay to talk about Latino folk, youth folk, LGBTQ, SOGI, et cetera, but somehow Black people were not on the table to be talked about, but to be enveloped in some, I don't understand it, way. So I am obligated to ensure that our communities are represented as I speak to you today. So I'm also representing the larger Black community as well as other folks who are disenfranchised. So, sorry, back to the slides. I don't know what happened to my slide. No. Where'd they go? All right, so that's BB Moore Campbell. Next, please. So the next slide is, I don't know if you know who this is, but this is Lois Curtis. And the reason that we have the Olmstead Act is it is the U.S. Supreme Court Act for 1999 that basically says that people with disabilities, including psychiatric disabilities, of which she has multiple disabilities, have the ability to live freely in the community of their choice. And she fought for that in 1999. This is an extension of ADA, and yesterday, or the day before, was the 32nd anniversary of ADA. Remember who she is, look at her, she's a Black woman. She fought for this, and she got it. She's still living today. She's a fine artist who I believe lives in Georgia now. Okay, this next slide is of somebody who's from my community. I don't know if anybody who knows who this is, but this is Miss Maitrice Richardson. And back in 2009, she was picked up by the police up in the Malibu kind of hills area. It appeared she was suffering from a mental health condition. She did not pay her bill at a restaurant. The restaurant called saying she was acting strange. She did not pay her bill. The police came to pick her up. They took her up to the station. She did not live in the Malibu area. And they called her family and let them know that she was there. And they determined that, she's acting strangely, but nobody did any kind of assessment. Nobody thought about, thinking about an assessment for 5150. Instead, in the middle of the night, they let her go in the middle of Lost Hills. If you know what Lost Hills is, the name says it all. Not a lot going on up there. And they let her go without any money, any car, any keys, nothing. She went missing. I asked NAMI Glendale, can you help us? Help us find this woman. Clearly something's gone wrong here. I asked NAMI California, help us find this woman. The family asked, and everybody said, we have to maintain relationship with law enforcement. We can't help you. Except NAMI Urban LA, BB Moore Campbell. Now, BB Moore Campbell had already passed away at this point, but BB Moore Campbell started NAMI Urban LA with 5 other people. So what happened to Miss Maitrice? A year later, her body was found. Actually, it wasn't a body, it was skeletons. Her driver's license was next to her, but there were no clothes, no nothing. And her, not to be graphic, her head was decapitated from her body. And that was not done by animals. So a whole year goes by. She's missing. Please remember her name. Next slide. This is Miles Hall. And many of you should be recognizing this name because we have a bill named after him, which is the AB 988 Miles Hall Suicide Prevention and Lifeline Act. So Miles Hall was killed by the police when the family had no other choice but to call 911 for support. And, oh, by the way, I should say Maitrice died at the age of 24, and Miles Hall was killed at the age of 23. Now, we don't want to talk about Black people, but the act is going to help everybody. It's not an act to help Black people, it's an act to help everybody. So this idea that somehow we can't talk about Black folks because it's centered and only for Black folks, no. And I don't agree, of course, that, a young man should lose his life, but at the same time, I want it to be clear that we have to talk about these things, we have to say their names, we have to understand our history, we have to look at their faces, because these are the faces of the people everybody's trying to help, and it cannot be excluded of Black folks who have different experiences. Next slide. So I'll be blunt. Sorry, Stephanie. Care Court. I'm sorry, right? Yeah, whoop, whoop, whoop. All right. So really, Care Court, which the term there is the Community Assistance, Recovery, and Empowerment. We're having a hard time understanding how does court equal care? How does court equal anything voluntary? It is sort of a psychological coercion, for lack of a better way of putting it, when you put it in any kind of court situation. How does court really equal recovery? Recovery consists of health, home, community, and purpose. I haven't heard much about some of those components, and in the evaluation, I haven't heard anything about measuring real components of recovery. And I don't believe that recovery, and neither do constituents, agree that recovery is full empowerment and autonomy. Now, sometimes people say no, and they say no for a reason, because it's the only autonomy they have. It's the only thing where they can get their control back because people have taken control from them. And it was actually Dr. Beck, Aaron Beck, who is the developer of CBT, who really discovered this idea that no has a lot of power, and it's not always about being compliant, but it's about listening to the reason behind the person's no versus just saying it's a no. And then also we talked about court doesn't really equal permanent and supportive housing. I'll get into that in a little bit. So next slide, please. I have to look at my slides down here because I have sort of bad vision, but I like to put this slide up here because sometimes I'm trying to understand what problem are we solving. I think Stephanie did a pretty good job of kind of laying out many of the issues that are out there, but I think a lot of times, the court issue is putting a Band-Aid on a gaping bullet wound. And really, what is it that we're trying to do that will help the most people, especially those that are most vulnerable? When I say the most people, even of those 7,000 to 12,000, what are those things that we could be doing? Sometimes, next slide, sometimes peer voices are considered to be very radical. Oh, it's so radical, talking about your rights over everybody else's rights. But Angela Davis says that radical simply means grasping things at the root. And that's why I like to look at data and talk about experiences as well to understand really what's underneath the iceberg, what really is at the root. Next slide. So this is my famous elephant slide. And I use this slide to help sort of ground us in the fact that everybody is having an experience with this. Everybody's touching a piece of the elephant. Some people are touching the ear and saying, this is the elephant. Some people are touching the trunk. This is the elephant. My father and I used to argue all the time. No, I don't have schizophrenia. Yes, you do. No, I don't. Yes, you do. I was touching a piece of the elephant and was having one experience. My father was touching a completely different, seeing it from a completely different angle and having a different experience. As I became better, I had a better understanding of how to step back and take all of these pieces as part of the elephant as important to informing the work that we're doing. I sadly don't think the governor has done that. The governor has yet to sit down with a large group of people who do not agree with Care Court. I don't know, is that democracy? I have no idea. We vote, by the way, but I'm just saying that, the bill has been crafted without the input with the governor. He has, we see pictures of him in press releases with all the supporters. He has meetings with the supporters, but he has yet to sit down with people who don't support the bill. We are Californians. We are voters. He represents us. Why isn't he heard what we have to say and sit down and talk with us about what are some other things that we could be looking at that are outside the court system to support this population? Next slide. So we talk a lot about stigma and, the A word, anosognosia, and a lot of people actually are so uncomfortable with the stigma associated with mental illness that they'd rather suffer in silence than get the help that they need. And so we have to understand, too, that sometimes people are suffering from a lot of different things, whether it be intergenerational and racial-based trauma, whether it be domestic violence, whether it be, and those things turning into symptoms that are maybe delusions or hearing voices or any of those sorts of things, and they don't want to tell anybody because they rather suffer in silence. When speaking on a radio show about Care Court with a family member, the family member basically said to me, but you don't understand. You're in treatment. You're in recovery. I've had many family members say that to me, and I've also had a legislator say it to me. And I find that the most stigmatizing thing I've ever heard. Why? Because you would never say that to somebody who is in remission from cancer at any stage. You wouldn't say it. So why do we say it with people with schizophrenia? Why would we want to speak up then? If we're not taking medication, you don't want to hear from us. If we're taking medication, you don't want to hear from us. If we're doing better, you don't want to hear. It's like you can never win. You can never win. And all we want to do is be part of the solution because we've had these experiences on the ground. And we want to inform you from an appreciative inquiry standpoint about what things would really help. How would they help? And as a person of color and people of color, LGBTQ2SI, SOGI, we want to be able to tell you our experiences and things that were helpful that are not fully funded, that are not even funded at all. So this is next slide, sorry. I'm going on and on without my slides. Don't worry about reading this, you'll get the copy. It's like really teeny tiny, I apologize. But this is from Dr. Ruth Shim. She's at UC Davis. I think, is she on okay, so you know who she is. So I love this slide because it helps really sort of talk about the social determinants of health and the interplay of social determinants of health on people's mental health, on their health as well. And so, when we understand all of these intersecting and interplaying, sorry, sometimes I lose my words. Yeah, okay, so let me go back. So when you're looking at some of these things that interplay on your health and mental health, like homelessness and housing, food insecurity, transportation. Oh, if they don't show up to care court, well, maybe they didn't show up, they didn't have a way to get there. Maybe they didn't show up because they were late, because they did have a way to get there, but it took them longer to get there. So I think we have to understand all of the different things that people are going through in order to even show up for stuff. And how are we addressing those things rather than just looking at reducing symptoms, for example. But a lot of these things also are unfair and unjust distribution of opportunity, particularly for people of color, and I think Stephanie touched on that. So we want to make sure that we're paying attention to these things. And again, understanding the next slide, please, the life that people have to live and the barriers that they have to overcome every day, just to maybe get a glass of water, maybe just to be safe. There are different barriers that people have to overcome, especially if they're people of color, that may be seen or unseen, that are structural, historic, and institutional, that remain even in the midst of care court and exist within the court system. So how are we going to trust the court system if these things are already existing within them? Next slide. When we talk about overdiagnosis of African American men in particular, or African Americans in general, I want to be very clear that we can train people on assessments, but we have to understand the bias that is embedded with the assessment from the very beginning. So this is from Dr. Cartwright, who came up with a couple of very interesting thoughts way back when around drapetomania and diagnosing enslaved Africans who ran away as having a mental disorder because they were running away from slavery. And that made sense to people. He also had a treatment for that, which is treat them like children. Take everything away from them. They don't know what's best for them. He also had another diagnosis when people weren't willing to work. They ran away and they came back and they weren't willing to work. And that diagnosis was, kind of in just layman's term, rascality. There's another term for it in Latin I cannot pronounce, but basically it's rascality. And the treatment for knowing, you would know that one of your enslaved folks had this disorder because their skin would have all these lesions on the back. Why would the skin have lesions on the back? Because the treatment of running away and of having this rascality was to whip people. So were the lesions part of the disease, or were the treatment for the disease causing people to believe they had the disease? It's like, it's ridiculous. But unfortunately, this perpetuated kind of underneath how we understand and live and recognize sort of the experiences of people of color. So I can give you another example. Next slide, please. That's more recent. All right, So these two slides are for medications in a general medical journal, because at this time, this is in the 50s, you're not allowed to do a direct-to-consumer advertising. So advertising for medications happened in medical journals. To who? To doctors. So in the 50s, they were coming out of a war. Women had worked in the war, so they continued to work, but they also had to continue to take care of the children and take care of the home. So they were overly stressed. They were presenting with all sorts of emotional problems, and the DSM-1 happens during about this time, and they defined schizophrenia in the DSM-1, and I am not a diagnostician, just so you know. I'm just very interested in stuff. So they describe schizophrenia in the DSM-1, which is about that big, as having an environmental base as well as a few other things. But basically, there's environmental stressors that cause people to have sort of these symptoms. And so it's a rise of medication. And so what we see is a high number of women who are now hospitalized and given medications because they can't do the dishes or they can't take care of the kids. That's really what's being communicated if you look at the image, right? So I think that's very interesting that the role of domesticity changed, causing women to have stress, but it was seen as a mental illness in which they need to be medicated so that they could do the dishes, so that they could take care of the children. It's not the point of recovery. All right, it's not the only point of recovery. So in the 70s was DSM-2. And during the 70s, of course, is the rise of the civil rights movement. It's sort of in the middle of the end of the civil rights movement. Next slide, please. And when you're looking now at the ads, we're portraying black men as angry, belligerent, fist up. Red is a color of anger. And what does this say? Assaultive and belligerent. Cooperation also often begins with Haldol. Now we start to see the demographics change in state hospital, and you see less white women, usually young married women, and an increase in black men diagnosed with schizophrenia. That increase has never stopped. And this is where it started. So I have to share this information so you can understand it doesn't just start because it started. It starts because of how our history is, and it's still continuing. Next slide, please. And so this is a slide from, and I will say, when is this? This was from May, I think. April or May? Hold on, what slide is this? Do you remember? March? Okay, thanks. This is from March when Stephanie's shop actually did a presentation for stakeholders on CareCourt. So we know, she said, that there have been several changes since then. But I think this is really interesting because it starts to, again, sort of have this implicit nature in it. And they describe sort of a scenario. This is a made-up person. It's not a real person. It's just a person kind of giving this scenario. This is a woman who has diabetes. She also has schizophrenia. She's also living in her car to keep safe. We don't know why she's living in her car. She could be, being have domestic violence or abuse or something like that in her house, and living in the car is a wise and safe place to live for the moment. But nonetheless, it says that she has diabetes, and because her symptoms are exacerbating, that she could probably be a candidate for CareCourt because she also can't take care of her diabetes. Next slide, please. So the next scenario is of Victor. And Victor is, again, a person who has either a schizoaffective disorder. You can see he's black, African-American, dark-skinned. It's kind of hard to tell the ethnicity, but certainly he's not white. And suddenly we have a substance user. That's interesting. So I really got concerned about what story is this telling about black men and substance use and sort of the black addict, the black drug user, I got worried about it, and I said, but maybe this is statistically accurate if we look at our California population. It isn't. So actually, African Americans are dying at a higher proportion rate of things like diabetes and cardiovascular disease than other populations. So in fact, the previous slide probably should have been a black person because it would have been more representative of the population and issues that the population is having. I find this one fairly stereotypical. So I did bring it up to the office, and I retrieved this 2 days ago, and it still looks exactly the same. I recognize it's a public document. But there's no notation about, wow, maybe we should make a notation that, we recognize that statistic, blah, 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 but it's still this way. So now how am I supposed to trust, and how is our community supposed to trust that people really get it when we're talking about what's impacting communities of color and why we're not trusting the system? Or systems, because it's more than one. Next slide. So this is kind of where it all started for me with Care Court. And yes, I think at the beginning, Care Court was sort of, being talked about as resolving homelessness. Of course, we know that's not possible with 7,000 people. But if we look at our census data, we know that for African Americans account for nearly 40% of the state's people who were unhoused, yet we only made up 6.5% of the population. So that says right at the beginning you have a huge disparity. So if you have this disparity of over 40% of the population who are unhoused, who are Black, and that same population is overdiagnosed with schizophrenia, who's going to qualify for Care Court? Well, and good luck for us maybe getting to court. You see what happened to Miles Hall, and you see what happened to Marquise Richardson. So that's the concern. If police are people who can actually put in a petition, will they? They're not without their own biases. So this is scary for us. I just want you to understand, if we're saying no to stuff, we're saying no to stuff. Anosognosia does not mean that we don't have nausea or Gnosticism about other things that we want in our life. We may not agree that it has to center on the symptoms of a mental health condition that somebody else thinks needs to happen, but there are lots of other things that we have interest in, concern about, but it goes out the table when we throw down the A word, anosognosia. So I want us to also recognize, of course, we know sort of the affordable housing, the shortage of affordable housing. We don't have much as far as housing first models. I'm sorry, I lost my train of thought. Housing first models, which is of course a wraparound, but housing first we don't do very well either because people don't understand, I think, how to really implement housing first where you're not having a lot of rules and restrictions that you're not supposed to have in order for people to be housed. Next slide. So I want to bring to your attention, this is an old report, if you will, from 2012, thank you, right? Which is the We Ain't Crazy, Just Coping with the Crazy System. Yeah, that's what we do as Black people. We are coping with the crazy system. And this is our language, so I don't want people to be offended by the term crazy. This is the language. There was no code switching here. This is the language that the community used. This is the CRPD report, right, from 2012. And there were recommendations that were made in this report. Some of them have moved forward. Many of them have not. And where is that report now? So next slide. I think it's important to draw attention to the California Task Force study and develop reparation proposal for African Americans. This was the interim report was sent to the governor June of 2022. It's 10 years later from the other report that I just showed you, the We Ain't Crazy report that I just showed you. And in this report, there are several recommendations that are made, and the task force, this is the governor's task force report. If you have not read it, take all 492 pages and, I don't know, take a gander. It's a big report, but it has to be a big report because this has been going on for generations. But in this report, there are recommendations made to the governor that, quite frankly, Care Court actually is contradictory to. So let's look at the next slide. Next slide. And I'm sorry it's so tiny, so this is just like violation, PowerPoint 101. I really apologize. So I'll just read out this is on page 23 of the report. There's an executive summary at the beginning if you don't want to read all 492 pages. But the first thing is eliminate anti-Black healthcare laws and policies and anti-Black discrimination in healthcare. Why are we passing something that's possibly anti-Black? I don't understand it. Remove psychological harm from race-related stress. Why are we adding court? Civil, it's still related stress. And if they're going to be a predominantly number of African Americans who are subjected to this kind of pathway, Why are we adding more psychological harm, trauma, and re-traumatization? Identify and eliminate discrimination and systematic racism. Don't think this does that. What about inequity and access to healthcare? It's trying to address inequity to healthcare, but it's doing it again through a court process. As I say, court has not been fair, kind, or healthy for Black folks. And in general, for people in general, but I think particularly for Black people, it hasn't been a place where we find a care and recovery. So funding needs of health-focused community organizations. I run a podcast called Unapologetically Black Unicorns, and I have a special series called #BlackMentalHealth, where I talk to Black Californians about what do they want to see moving forward in their Black mental health. I spoke to Toni Mitchell, who works at Faith in the Valley, and she's in the Central Valley in a rural area. She said they're not funding things like safe Black spaces. They've tried to fund safe Black spaces, which is here in Sacramento area. They can't get it. Funding needs of health-focused community organizations. That could be funded, right? The lack of race-conscious public health policy. Okay, maybe it's race-conscious now, people are getting it, but why are we moving something forward that doesn't really support folks in the community? And of course, implement Medi-Cal reforms to increase flexibility for the use of community evidence-based practices designed, tested, and implemented by the Black community, and reduce the tendency to use culturally bankrupt evidence and evidence-based practices that are not field tested. One of the terms that really kind of gets our goat is EBPs, because we get stuck with this idea that somehow they are for everyone. They're evidence-based for everyone. They are not. We know that certain folks are not helped by cognitive behavioral therapy. I was very fortunate to meet Dr. Beck and be able to tell him that to his face. And he knew it, actually, and so he's developed some other things. Well, he's no longer living. He died a few months ago. But the reality is that we have to recognize that many of these evidence-based practices are not evidence-based for communities of color. They're not evidence-based for people who are LGBTQ or SOGI or transgender. They're not. So why would we subject people to a care plan to practices that may not be the most effective for them? Next slide. All right, so I'm beating everybody over the head. I'm sorry. I'm not sorry. I'm an unapologetically Black unicorn. So let's look at some evidence here around psychiatric advance directives. I think we tried to pass the psychiatric advance directives bill this year. I don't think it went anywhere. But here we understand the value of peers in the effective psychiatric advance directives facilitated by peer workers on compulsory admission among people with mental illness. And what they found is that there are significantly fewer compulsory admissions than those in the control group. Of course, this supports, peer workers being able to facilitate psychiatric advance directives with the people they serve. I'm going to add something else here around advancing peer work. So when we first tried to pass peer legislation here in California, well, several times it was vetoed. Before SB 803 was passed, the governor vetoed SB 10, I think it was, before 803. I don't know, too many numbers. But the reality is we found out that the veto was because of course, it triggers Prop 30. Okay, well, so it triggers Prop 30. What that meant was that the state did not want to pay their federal share of the costs, the non-federal costs, to stand up a new workforce. They don't want to pay it, but they're willing to pay for court, but they're not willing to pay for peers. As a matter of fact, when you talk about homelessness, okay, I think you can do this in the next slide. Let me go to the next slide for a second. But I also want to talk about peer supporting family members. So there's nothing in here, I haven't heard one word about peer supporting family members. In one of the hearings, in response to, well, there's no housing, one of the authors of the bill just said, well, they can live at home. No, they can live at home. They'll live with their family members. Their families, they're okay if they know that they're under this court order for them to live at home. Where's the support for the family member? It's absent. So if a person is going to be living at home with a family member and the family member has no real support, we're going to be right back where we started. And the person may not want to live at home. If they don't want to live at home, where's the Olmstead violation? What was the point of Olmstead, of the person having that choice? All right, so next slide. So I hate to say once you get there, if there's no there there. There's just no there there. Having worked at County Behavioral Health, at the largest behavioral health system in the country, I will tell you we are bursting at the seams. There are no more seams, literally. There are no more seams. Providers are overwhelmed and overworked. They're taking on more roles than even what they're supposed to be taking on. People come into our system and they don't leave. If people come in and they don't leave, if we don't have flow, we will never have access because we can't keep making the system bigger and bigger and bigger. It's supposed to be a safety net, not an entrapment. How do we get entrapped in the system? Because we're not looking at true recovery. We're looking at managing symptoms, making sure people have housing. Yes, housing is critically important. What did Tom Ansel just recently write about? The importance of belonging. I didn't see any measures of belonging in the evaluation. I didn't see any measures of health, home, community. Okay, so health, we see some of it, but we don't see other things related to a person's health. When you take some of these psychiatric medications, they cause side effects that cause our death, period. But we're supposed to comply to taking something that has a side effect that may cause our death, period. I've lost my vision. I had thyroid cancer. Nobody believed I had thyroid cancer. I didn't believe I had thyroid cancer. I knew I had something wrong, and everybody kept saying, well, you know, those are delusions. Show up in the ER, they see my psych record. Why? Because we have electronic health records, so you can see what medications I'm taking. They see what medication I'm taking, and they dismiss me as delusional because I'd lost my voice and I sounded like a very sexy, albeit Lauren Bacall. She's super sexy, but that's not my voice. And I could barely talk. I was in a lot of pain. And they basically just let me sit there. And I was damned if they were going to do that. So I sat there and I stared them down till they agreed to see me. And they were doing it kind of like, let's just sit her in the back. Let's draw some blood. It'll look like we're doing something. You know, she might be drug seeking. We don't know. Until they got my blood draws back and they were like, oh, there's something seriously wrong with her. And that's when they found out I had this huge lump in my throat, which turned out to be a thyroid cancer. And lo and behold, also parathyroid cancer, which is really quite rare. And this has been going on for years, and I've been complaining about it for years. But you have schizophrenia, who pays attention to you? So I think, you know, these are other things when we're talking about stigma and the systems, because it's not just one system, it's several, and the impacts on, you know, the people who are receiving services. Let's talk about the workforce. What workforce? You see any? Where are they? San Diego, 8,000 short. 20% of the, if I have it right, I'm probably going to have to read this one. Oh, sorry, I need me to be here. Let me just read this so I make sure I have the numbers right. So a recent study of the Board of Supervisors in San Diego County found that they have a shortage of 8,000 mental health providers across 12 occupations. Nonprofit CBOs across the state, the backbone of service delivery in California, and those organizations who would be called upon to do the work envisioned in this proposal are reporting vacancies for clinical positions as high as 20%. This is not unique to California. This is across the country. Where are these people going to come from? And if we move people around, we're just moving people around. We're not really creating any capacity. And so as we move people around, the 7,000 to 12,000 people who may move to the quote-unquote front of the line, there's somebody who's moving to the back of the line. When somebody moves to the back of the line, they're going to end up in that care court line. We just created another line. We didn't really create capacity to help people in the long run, I think. And it's not just me who thinks this, by the way. Next slide. Oh, I hate to bring up the complexities. Everybody hates complexity. I think politicians hate complexity. Politics are very complex. I hate it. But the reality is, doing things that are simple, very easy for people to do when they want to do it. But really tackling the complex problems to help people in the long run, even if it's a small population of people, you need to talk to all of the people who've been affected by these systems, particularly those who've been disparately impacted, to find out what are some better ways that we could be doing this. Okay, I think this is my last slide. Oh, next slide, I'm sorry. My next slide is, okay, all right. So I love this writer. I cannot pronounce her name. Adichie, I think it is. And she talks about the single story, which creates stereotypes, and the problem with stereotypes is not that they are untrue, but they are incomplete. They make one story become the only story. And it feels like in Care Court, the only story has been about families. And I think that is a story that needs to be told, and we need to help families. I have a family. I asked my dad, what do you think of this? He said, no way in hell. Where's his story? So the consequence of the single story is this: it robs people of dignity. It makes our recognition of our equal humanity difficult. It emphasizes how we are different rather than how we are similar. And I think because Care Court has split us, it split the consumer movement. Black people left the state consumer network because they were not focused on our issues. Should never happen. Families and consumers are fighting. Like, seriously, we're all talking about the same group that we want to help. The question is, how do we want to help them? Last slide, please. So if I had to think of some OAC actions, one more slide, is that I would love to see the use of, well, first of all, I would love to see OAC take a position. And I get I get why you don't want to take a position. I get it. At the same time, I think that's possible. Also, using MHSA aligned with recommendations in the reparations report. If you haven't seen the recommendations, take a look and crosswalk them against proposals and work that the OAC does. Listen to people like Tony McNeil from Faith in the Valley, in the Central Valley, who says that they're seeking funding for things like Safe Black Spaces and other programs like BEAM, for example, and peer respites. We have 8 peer respites in the state of California, 8 in this huge state. In LA, we have 2. One functions primarily as a peer respite. The other one functions as a little bit different, but it calls itself a peer respite, which is fine. I'm in a county of 10 million people, and we have 2 peer respites. This is an option for people who may not be ready to seek, quote unquote, conventional treatment, who need extra support. There's no there for them. So can that be an innovation program of setting up something that they have in Connecticut, which is called Amani Breakthrough? There's a peer respite in the Black community. Can there be sort of culturally relevant and community-defined practices and things like peer respites that are funded? Analyze outcomes based on flourishing and recovery, not solely on mental health symptoms reduction and housing compliance. And please, please, please disaggregate the data. We can talk about LPS. The problem with LPS is 50% of the counties weren't reporting. For those 50% that were reporting, there was an overabundance of Black folks who were subjugated to LPS, under LPS orders. We're still overrepresented, so we're not fixing the problem. We always get kind of like, I don't know, it's second class, we don't deserve second class. Develop innovative prevention programs that address gaps and needs, especially those for underserved, underrepresented, and inappropriately served communities. Ensure MHSA funding is not coercion-based, such as court programs, and proposals address how to eliminate use of coercion or even perceived coercion by investing in robust, relentless programs, practices to support the population, especially those that are in most need. And ensure that the stakeholder process is rigorous and peer involvement and leadership are meaningful and material meaning that they're paid. Okay, I talked about peer respite models. And I think there needs to be a strong message sent to the governor about the lack of involvement of people who do not support Care Court in order for him to have a better understanding of what are the various things that could be done that he hasn't heard yet. He's only heard one side of what things can be done. So with that, I will end my talk. Thank you.
Thank you so much, Ms. Merrick. And thank you, Stephanie. I appreciate both you, Ms. Welch. Thank you both for being here and for your time with us. At this time, I am going to once again ask the public comment period to start. We will close the public comment queue, so please make requests to comment now or as early as possible during this presentation. Commissioners. commissioners.
I
Are there questions or comments?
have comments and questions.
Thank you, Commissioner Bunch. I'm going to ask you to go
Thank
first.
you. Thank you both. Your presentations were both amazing. I was hoping to just talk a little bit more about Care Court versus AOT, because looking at the bill, and hopefully I have the most recent one, the Chapter 2 process, the criteria are the same as AOT. The care agreements are the same as the voluntary settlement agreements that are
But it's
that we
not.
see with AOT. The affidavit is the same. I realize that more people can petition for Care Court, but those are the same people that refer into AOT. And in reading it, it seems a little bit like people can get petitioned into AOT, and then after that commitment is up, then be petitioned into Care Court. So we're looking at multiple years of commitment. So given the similarities, and I understand there are some differences, but given the similarities between Care Court and AOT, has there been any research into the efficacy of AOT and what's not working versus what is working to try to close those gaps? Because one of the things I think that we're going to see is that even after people are petitioned in AOT, there's no services provided. Right? So Karis was talking a little bit about people not getting to court. Sometimes people are petitioned into AOT, and then teams have to go find them on the street because they still have nowhere to live.
Yeah.
It's hard to get someone to court when they're not housed. So I'm just curious if there's any has there been any research into the efficacy of AOT?
Well, if you'd let me first, I want to say I apologize because you did bring that to our attention. Several people brought that slide deck to our attention, and I'm sorry that it's still on our website. So I will take care of it when I get to where I need to go next. But I really apologize because we said that we were going to do that, and I think we agree with your assessment. And those vignettes didn't really reflect a lot of thoughtfulness on our part. I have to answer a question of yours though first before your specific question. The primary difference between AOT and Care Court is the court-ordered accountability and the ability for the courts to sanction the counties if they do not provide the services in the care plan. That's the primary difference.
But what would be non-compliance on the part of the county?
I think that, the care plan is submitted. It has services, housing. I don't know all what would be in someone's care plan because that's developed individually. It's up to the court and a process that we're still working through some details, but there would be an appeal process if the counties feel that they've been unfairly assessed as not providing the treatment that's in the care plan. So again, the court, that's within the realm of the court's authority, and the counties can appeal if they feel that they have provided the care that's in the care plan to an adequate level in which again, the court may find it inadequate. The individual themselves may find it inadequate and bring it to their counsel and use their counsel and the court proceedings to say that they don't feel like they're getting what's in their care plan. Another reason why we have something that they can elect the respondent. Sorry, it's a lot of legal terms. Can also get support from their supporter to help them in that process. Yes, the petition part's a little bit different. I don't think it's dramatically different, but that's the primary, just to answer your question, that is the primary difference. And certainly we did a lot of looking at how AOT had been implemented in other states, which is different than how it's been implemented here necessarily, and thought that the primary difference that we were really trying to solve for was to ensure that a level of treatment that we felt was needed for the individual and that was designed with the individual's direction was what the court was going to hold the county accountable to delivering.
I think my concern with that is that, and I was the AOT psychologist, so I've seen the care plans. I think my concern with that is that those services don't exist. So we're petitioning people into services that aren't available, and not just through AOT, but through diversion. And I know MIST was mentioned here. And a lot of what would happen is you're petitioning people and you're saying you need to do A, B, and C, but then there's an issue with linkage. Because when you're trying to put them in a program, programs have 6-month wait lists for an intake or 3 months to see a psychiatrist. So I'm not sure how we fine counties for noncompliance for services that aren't there. And I appreciate that you listed them earlier, all the things that have been done. But the things that I see on paper and the services that are out there in practice are really hard to find.
And I would have to say that the counties are contractually obligated to serve this population. I don't know what else to, I mean, that is how our system works. And again, I'm not really answering your question about the effectiveness of AOT, but I did want to make sure that that was clear, that is the primary difference, which why it wouldn't make any sense to go back and amend Laura's law. It made sense. And again, I think one thing, in addition to with assisted outpatient treatment, is that you do in many cases have to have multiple failures. You have to have multiple hospitalizations, jail days. I think the goal was to try to intervene before someone had to experience too many negative outcomes that were the result of an untreated serious mental illness, specifically schizophrenia, which is not AOT either. AOT is a larger group of people with mental health disorders. I am not an expert on the research around AOT. I'd be more than happy to have the person in our office who has done that send you a follow-up response.
Thank you. Yes, please. Yes, Commissioner Pond.
Well, first of all, I want to just say I appreciate the presentations, Ms. Merrick. I think you did us a service to kind of humanize what otherwise would be an intellectual discussion. It's a human discussion, and I appreciate that. So I have several questions, and it's just born out of my desire to understand better. I like to say, and I say this respectfully, I think I've always found Sacramento, when it comes to rulemaking, it's the land of good intentions with unintended consequences. And my fear is the unintended consequences. So I want to better understand a few things. A couple questions real quickly. Is the individual or the respondent, are they represented?
Sorry. Yes, they will be provided counsel.
Okay. So you stated it doesn't create a housing entitlement, right? By one's participation, that they don't have a legal right to housing. However, it's a component of this program. Is there a potential, obviously you indicated that they could jump the line for housing because
the judge can prioritize care.
Is there a potential unintended consequences for other vulnerable groups seeking housing by that? Because obviously housing, affordable housing is, that's an endangered species here.
Well, I think that I actually think, I can't speak to the affordable housing comment, but again, we are investing $1.5 billion going directly to county behavioral health, not going to the housing system, but directly to county behavioral health it's available now that they can use to house this population, recognizing that many of the investments that we've made, the $12 billion, the $3 billion in the community care infrastructure piece, which, by the way, peer respite is an allowable thing to use those resources for, and we would like to see people apply to use them that way, will not materialize in the first 5 years of this program. But I'd have to say with 7,000 to 12,000 people being the target, with that $1.5 billion, I actually think that we can find, and we will be and can be resourceful to find a safe place for individuals to be so that they can participate and be active and involved in their treatment. I think this population is incredibly vulnerable. If we look at the criteria, I think that what we're trying to do is really prioritize access to a safe place in the community rather than jail, rather than the state hospital, rather than being conserved and placed in an IMD, that these are community-based settings that we want and believe that if they're in a community-based setting, like an enriched board and care, it's a strong, healthy environment to do good work. And so I don't think we've done any kind of like modeling to see in which county this may, unfortunately, put someone in front of them. But I guess my only answer is that I don't know if you can get more vulnerable than this population. And we believe they deserve to be prioritized for the housing that's available.
And one last question, one observation I have is if I peel back the onion a bit, it seems to me that part of this is to compel county behavioral health to meet the mandate that they already have and serve this population more robustly. Is there other ways to achieve that aim absent care court?
I would agree with you that that might be something, but that's certainly not the reason for care court. Okay. I think that we worked with teams of outreach workers, psychiatrists. We also work with peers and family members, and we did also work with peers who helped us think through what was needed. And so I think there is a belief that for a small group of people that the symptoms associated with schizophrenia and other psychosis spectrum disorders can lead to a level of impairment where an individual may not be making healthy medical decisions for themselves or is incapable of doing that. And we think that we can help those people without having to conserve them. And so I also would say that I agree with many of the things that you said. And I very much agree with, I personally spent much of my time over the last 6 months listening to people's concerns about care court. Because it was important for my role and the other work that we do. As I mentioned, we do a lot of other things than just care court, and we're working a lot of other major proposals. And I also believe that people will say no because they're afraid or scared, or the engagement hasn't been good, or no one's ever treated them well ever when they got a mental health service. And why would they want to go back and get more? So it's not an either or. I think it's both, but I definitely think at the core, which is why this is such a small group of people, really very focused on a particular diagnosis, unlike Laura's Law, unlike some other pieces, and recognize if we can give robust, assertive treatment that hopefully in that year time, that there's a transition plan, and these are now people who are able to successfully live independently in their choice of a housing placement in the community. But I do want to be clear, I think it's a misnomer. I've heard it a lot, that people think that they must go to court and then the court sends them to a hospital bed. And that's not at all. There's no ability for the court to place somebody in a hospital unless they meet the current LPS criteria. I suppose if the individual themselves wanted to be in a hospital and they chose that as part of their care plan, but again, you have to meet medical necessity to be in those kinds of placements. And so, these are really individuals who will be in our community-based system of care. I think I lost my train of thought, to be honest with you. Yeah.
Can you clarify, is it possible that someone goes from AOT into care court? So AOT, I believe, has the same, where you can be petitioned for up to a year into your voluntary settlement, but it looked like you could then refer to care court, and care court can also go up to a year.
I actually don't know. I'm going to double check on your question, because the intent isn't to extend. Yeah. The intent is maybe care court's a better fit for the individual rather than AOT. So but I'll check and get back to you. Looks like I better start making a list.
And where do the services come from once the treatment plans or the care plans are coordinated? And say it's saying that the person is agreeing to psychiatry and therapy, who provides the services?
The County Behavioral Health Department is responsible for not providing the services, but putting the plan together, just like they would for anyone else in the specialty behavioral health system. There's also a provision for commercial plans to be billed for the services that County Behavioral Health has to provide if the individual has commercial insurance.
And I know Karis mentioned this earlier, but there's a major shortage in mental health providers right now. Is there a way that that can be addressed within this plan? Can it be built into it?
Yeah, it's an excellent question. I think this is my sleepless night issue that I have had for the last year, especially we had it during COVID. We're interested in any ideas, actually, and have started to meet with some of the guilds in particular, because we do have, the problem with this is there's no lack of resources. We have lots of resources. We don't know how to bring the right kind of people on quickly. I think peers, family members, community health workers, we created this new concept called a behavioral health coach. These are all people with different kinds of lived experience. Maybe they're formerly incarcerated. Maybe they were in the foster care system. It doesn't necessarily mean that they had a mental health challenge. But I think that that's the wave of the future, and we need to, as quickly as possible, build out that system. But I'm not going to say that I don't disagree with you. I think we have a literal crisis on our hands with the lack of behavioral health workforce. But we also have resources, and so we really need to start thinking, this would be something you guys could assist with, about solutions. How do we create the providers of tomorrow quickly? So anyways, yeah.
Thank you. I'm going to have Commissioner Chambers and then Commissioner Gordon. Thank you.
Just a quick observation. It's been noted that a lot of peers, consumers, particularly Black peers, disability rights advocates, human rights advocates are starkly opposed to this plan. How are you addressing that opposition, as we are the consumers and reflect the folks that you potentially will be serving?
Yeah. Thank you for that. I respect your opposition. We respect your opposition. We've met with several different leaders, and the thing that I think I would say, as I was outlined in my slide deck, is it's definitely a problem. Like, there's nothing else to say that it's not a problem. Not doing care court doesn't solve that problem. We have to solve that problem. And so...
Who's the we?
All of us.
So the consumers?
Well, I think our behavioral health community, the research is, just as you mentioned, hasn't been researched on all of Californians. I think the research, the way that the service delivery, I guess my point is that not doing care court isn't going to solve this problem, and I think we need to work on it. So I would say that out of anything that we've learned, and I can speak for agency staff, this has become the issue that was the takeaway of, oh my goodness, we have a tremendous amount of work to do, and we would not do it without your voices and involvement. Absolutely.
Another follow-up question. In your slide, you mentioned trauma-informed policies and procedures that you'd implement to address racial biases when we know that this is going to impact. We've historically had these challenges, particularly with people of color. What does that mean? Like, that just seems broad. How does your...
Yeah, so hopefully it's not a typo, but it could have been. It's trauma-informed policies and practice, and I think it says bias elimination training. Yeah, my slides could be inaccurate, but that's what it says in the actual statute. So they're two separate concepts, but yes, they are related. DHCS will be responsible for implementing the training and technical assistance component, and they are required to hold a stakeholder process to work with people on how to implement that. So we didn't, in drafting legislation, we wanted to be broad so that we would have the flexibility to become specific with other people's input.
Another thing, on the supported decision-making point, it's noted that there was variances in your slide. What I read in the package was that the Department of Aging would be supporting the supporters, and then your slide said DH. Maybe that's the same. If it's an office.
You're accurate. We've had so many amendments. The last set of amendments actually moved the supporter responsibility and the responsibility to provide supportive decision-making training to DHCS. And part of the thinking for that was then we can maybe make supportive decision-making training available to a whole bunch of people, not just related to care court. And so that was the primary reason, and it was a recommendation from stakeholders, and I think it was a good one.
They would also be administering the supporter role too, right? Like managing that. What's the rationale for not bringing it into the community? Supported decision making is really focused on being client-centered and on the individual. If the government is administering the supporter program, how are we going to make sure that that's equitable and making sure that the consumer's needs are addressed when the government is managing that?
Well, let's talk more about it. They're administering it, but it's like up here. They're up here, and everybody's out in the community. So the supporters are going to be in the community. They're going to. So I think that we need to. I'd be interested in your ideas about how to make sure that the training that DHCS provides is adequate. And we are having ongoing. This is a new thing. It's definitely not a new thing for everybody, but it's a new element that we certainly haven't codified. And so I think we're really interested in doing more work on how to flesh this out.
And the last thing, I've heard little to none about actual community-based services and ensuring that, because I'm on the ground, we're on the ground, and we know that the counties have no ability to implement this. They're like a number of people have noted, like they are strapped at the seams. It's just not possible. How do we ensure that CBOs, peer-run organizations, other organizations are also at the front of the line that can compete for some of these resources to serve our people? Because I just never hear the community. It's all about the counties, and we are the community's the lifeblood. We're the ones really on the ground. So I just want to just make it a note and put it on record that we really need to change the language to always focusing on the county and really focus on really the people that are on the ground, the CBOs.
Yeah. Thank you for that. I think just by the way that the court is going to hold the county accountable, that has to work that way, but I think it's really important. I think one of the things that we learned in going around, when our agency staff learned in going to the roundtables and having listening sessions, is how much and how critical, actually essential, I just want to use the right term, essential local CBOs will be to communicate what care court is and what it is not, and what it's going to look like in your community. It's potentially going to look different, community by community. We can talk a little bit more about how to strategize in doing that, and how our judicial branch partners are going to work with their presiding judges to set things up. But I don't think it'll be effective without the meaningful involvement of community CBOs.
To kind of piggyback on Commissioner Chambers and something Ms. Merrick said, that's kind of my concern, like in the back of my head, is how the county's going to implement this. See, that's my concern, working out in the counties and seeing the difficulties they have in behavioral health. And so you also mentioned legal aid is going to be the representative. So this is going to impact legal aid's workload, I'm assuming. So legal aid getting any funding? Okay, great. So that answers that question. But I am concerned about the county's implementation, because I know, just as Commissioner Bunch said, a lot of the services are just not there. So is there conversations to take all of this into consideration, building capacities for programs too? Because I really like the idea, because I'm a parent of an adult son who has schizophrenia. When I came to this commission, he was a minor. Now he's an adult. I get phone calls all the time about, and people are in crisis. And so, the system is fragmented, where do you go for help? So I do like a little bit of something. To me is better than a whole lot of nothing. So potentially I can see how this can help part of that 7,000 to 12,000. But I do have questions about the capacity of behavioral health to offer programs that are going to help this population, this severely impacted, mentally ill. And then you mentioned engagement. So what does engagement look like? Who's doing this engaging? Engagement is so huge, because if you fail at engagement, you're not going to go anywhere going forward with helping. So these are just my thoughts, and they're not really questions. I'm just kind of putting them out there because I do totally resonate with Ms. Chambers and Commissioner Bunch in terms of capacity on the ground once you implement something like this. Because what I don't want is for families to get trapped. Because that's what happens when folks come into the system, at least in child welfare. Families seem to get trapped in this spiral for, 12 to 18 months. So how do they come out of this better, or at least helped? Those are just my comments, and just part of a dialogue that I would hope is going to occur somewhere. And for sure, taken into Ms. Merrick's comments about the whole trauma piece and the history of that, and how that aligns with the possibility of what this could do. If someone is not mandated in because it's voluntary, but they feel mandated, because these referrals are coming from, as this report said, family, friends. I could put a referral in for this CARES program on Toby, and he could end up being caught up. So I wouldn't want him to be trapped. And so if I could talk him into voluntarily saying, okay, this will work for me.
Yeah.
So those, again, are just points of thought that have to be taken into consideration. But your presentation was excellent, Ms. Welch. Thank you. And also, Ms. Merrick, I was really spellbounded by it. So thank you both, because the opposite, just the information was very, very valuable.
Great, I'm glad it was helpful. I would say I heard what you said, and I don't necessarily need to respond, but I would share that we are still in active negotiations. Just generally speaking, there will be more amendments to the statute as it currently is written, and we are still in active conversations with counties and all the county partners about the administrative cost and other cost. The budget gave about $64 million for Care Court, the budget that just passed, but we recognize in particular, and this is related to you guys, because there's so many changes that have happened since we passed the Mental Health Services Act, including most notably the ACA, and our ability to try to do more to serve the mild to moderate so that they do not have to use the specialty mental health system. And our ability to do more preventative early intervention work in that space. But one of the greatest gifts that the Mental Health Services Act gave us was the concept of outreach and engagement, and funded it in a thoughtful way. So I agree with you, is what I'm saying, and I do think that effective outreach and engagement is essential for Care Court to work, and we have to have the right people doing that with the right skills, the right training, and potentially it could help us with a lot of other things that we do in our system if we find a way to fund and support adequately outreach and engagement efforts. We're trying to do some of that in CalAIM, and we'll continue to try to do it in other spaces around the transformation that we're doing in behavioral health, so that outreach and engagement is a core service in a behavioral health care plan.
Please, Commissioner Gordon.
Thank you, and let me echo my thanks for both of your presentations. I learned a lot, and Ms. Welch, I know how much work you're putting in to lead this overhaul of the entire system, moving it from treatment towards prevention, and that work is much appreciated. My question is around injecting the courts into this process, and my question is, were there examples of other initiatives or tasks that the courts handled as a specialty court that you modeled this initiative after? In other words, places where the courts were able to create leverage to make change locally and get something done to address a particular problem.
I'm probably not the best person to answer that. I was not part of designing that component. We worked very closely with our judicial branch partners in working through what the petition process should look like. I think a couple of things that I know that we looked at. One was the dependency court and some of the ways in which family court operates, really recognizing, for one, wanting to balance the rights of the child, especially if the child is in a ward of the state as part of the foster care system, with the responsibilities, frankly, of the systems that serve that child. In this case, this is not a child, but I would probably say that was the number one thing that was really looked at. But yes, we definitely looked at AOT programs that were designed in other states, that were different than the way that Laura's Law is designed here, and applied some of those learnings as well, most notably the petition process. The way our petition process works with AOT here is really different than anywhere else in the country, in that our petitioning process comes from our specialty, county behavioral health. That's not how it's necessarily designed in other places. I think also we worked very closely with our frankly, our very passionate judges who work in diversion courts and who work in collaborative courts, and we want to figure out a way to bring that collaborative nature to a civil court. And I'm learning a lot about how courts are organized through this process, and it is very possible that some of our judges who are very knowledgeable about mental health issues but have been sitting in criminal courts, kind of talked about this, the whole goal is to not have people be going through criminal proceedings, that they may be assigned by their presiding judge to be the judge in care court. We also looked at homeless courts and other community-based courts that are not actually held in a courtroom, but they're held in a multi-purpose room in a part of the community that maybe a shelter or a food pantry. We also looked at mobile courts, and we'll be looking at using telecommunications so that physically going to the court can be eliminated in some cases potentially, if not really, really minimalized.
Thank you.
Thank you. No other comments or questions from my commissioners? Yes? Commissioner Carnevale, please.
Thank you. I agree with everything being said, so I'm not going to add on to that. I just wanted to add one final thought. We are continuously faced with this challenge of the system is crazy and dysfunctional. It's not serving a lot of needs. I think it's wonderful that we're trying to create a program that seems to address a sliver of the problem, but we're always wrestled with the problem is bigger and the resources are smaller than we can possibly actually address. And I did. If my math is right, $1.5 billion sounds like a lot of money, but if my math is right, it's something like 1,000 houses for families per county per year. Maybe that will make a dent in Yolo County, but it's not going to help much in LA County. So the math doesn't really add up to the size of the problem. And so from my personal viewpoint, the only way we're ever going to really get our hands on these problems is by being involved earlier in them. We've got to get involved in early assessment and early intervention. We have the ability to assess children at risk before we even see any evidence of psychosis. And certainly at the point where we see that evidence, we should be getting involved and staying involved with those lives for their lifetime. And if we do that, then we're going to have a smaller problem. And as the business representative, I would say that I would guess that at the end of the day, it will cost us less money to do that than the money we don't have to solve the problems we have today. So we certainly have to make the resources available to address today's problems, but we've got to start investing more in early assessments, early interventions if a commission 10 and 20 and 30 years from now is going to have more hope than we have sitting here today to solve these problems. Thank you.
Thank you, Commissioner Carnevale. I want to thank you both for being here, Ms. Merrick, Ms. Welsh, and what Commissioner Chambers said, I appreciate that. I too had highlighted around the trauma-informed practices. I'm hoping that that would be across the entire system, from law enforcement to those in the court to the representatives, the judges, everybody, because there was the example given, if somebody does not show up to their court hearing, are we taking into consideration everything that's happening within that person's life? So to really be, and then you mentioned that there's going to be additional changes. And so I hope that just as you've heard and you represented that you are hearing from the community, that that continues to happen. And it sounds like it has, so I hope that you continue to do so, because and again, as we started this, that the changes are continuing to happen. So appreciate that, and appreciate that you continue to listen to the voice of the community. So I would like to say, and Ms. Merrick, thank you. I've learned history. I will repeat their names. I will remember those stories, and I think that's critically important, because we are building upon people's lives, and it is something that we should never forget. So thank you for that. I appreciate that. We're going to move forward with public comment, as there are no other commissioners' questions. Thank you. And okay. I would ask that we limit to 2 minutes, because we have many public comments. And I will ask, I'm sorry. So I will ask Ms. Merrick and Ms. Welsh, you are welcome to stay. However, when we invited Ms. Welsh to be here today, she did let us know that she has a hard stop at noon for another commitment. So we want to honor that. You're welcome to stay, Ms. Merrick, if you have another commitment. Yep, then we appreciate your time. So with that, we are going to move on to public comment. We have approximately...
We have 15.
We have 15 people that are going to provide public comment, plus we have people in the room who are also going to provide public comment. So we have 3 in the room, 15 online, so we are going to limit that to 2 minutes each, please. So Mariani, if you could please get us started. Thank you. Thank you so much, ladies, for your presentation. Greatly appreciate that.
Richard, your line is open. You may go ahead.
Hello, this is Richard Gallo from Santa Cruz, California. I thank both presenters for doing their presentations, especially the second one, for being relevant. On the care support role with Care Court, it needs to be a person with lived experiences and be paid a living wage. As far as the Oversight Commission, I strongly believe and oppose the Mental Health Services Act funding should not be used, anything relating to Care Court, because that's not the purpose of the Mental Health Services Act. Just like the last commissioner mentioned about the commission about intervention prevention, that's what they need to focus on, and that's what we're failing, not putting into our communities. Part of it may be on the county side, part of it may be on the Oversight Commission, or a combination of both. And there is no housing to place them. There is no services to place them. Counties like Santa Cruz, San Benito County, where they're gonna go? It's setting up to fail relating to Care Court, especially in our 2 counties. Thank you.
Thank you, Richard.
Next, we have Vanessa. Your line is open. You may go ahead. Go ahead and try again, Vanessa.
Hello, can you hear me?
Yes, we can.
All right, and now I put my headphones on just to make sure, and you can still hear me, yeah? Yeah, okay, see head nodding. Thank you so much. My name is Vanessa Ramos. I am a bicultural, bisexual woman. My mom is from Honduras and my father is from Armenia. I proudly serve Disability Rights California's public policy team. Additionally, I am a person living with disabilities, including a schizoaffective diagnosis. I strongly urge the commission to take an opposing position to Care Court. All evidence shows that adequately resourced intensive voluntary outpatient treatment, not court-ordered treatment, is most effective in treating the population that Care Court seeks to serve. Care Court perpetuates institutionalized racism. It infringes on individuals' civil liberties and does not provide necessary housing. The MHS OAC should oppose the bill on the grounds that Care Court would allow MHSA funds to support this coercive new court system and services. The MHSA was never meant for coercive and involuntary services. I do want to share that in my own personal lived experience, if I did not have access to food, water, and shelter, I would not have the ability to serve Disability Rights California in the way that I am. I would not have the opportunity, or I would not have the ability to be an amazing parent to my children, or to do many of the things that we're doing. So without housing, I don't understand how people would be expected to make treatment appointments that, like some of the commissioners mentioned, don't exist. And thank you, Commissioner Chambers, for uplifting the need for MHSA funds to go to peer-run community-based
Vanessa, your time is
organizations.
up. If you could wrap up your comments.
Sorry.
Thank you.
Yes, thank you. Thank you. I would have kept going, so thank you so much.
Thank you, Vanessa.
We have Raphael. Your line is open. You may go ahead.
Oh, hi, everyone. Good morning. So Rafael Henriquez, he, his series. I work with Safe Passages. We're a behavioral health services provider in Alameda County. Really briefly, just want to thank Mariani, Chair Madrigal-Weiss, Ms. Welch for grounding us in these policies we're discussing today, Ms. Merrick for sharing those stories and metrics. I want to also uplift the commissioner's comments and questions about some of the challenges that we've been discussing today, right? With linkage, with staffing, with the workforce. These are important parts of this initiative that I'm looking forward to hearing more about soon. And so unfortunately, although we've talked about accountability, it still feels like the emphasis is on the counties, but not so much on like the CBOs and the people who are most impacted by this issue. And I just wanted to say, as a Black and Latino man in my mid-20s, I just want to hold some space too for being overrepresented in some of the topics we're touching on today, but then also being underrepresented in the policy discussions and formulation. So I just wanted to bring a couple of metrics to your attention, and thinking about the statistic about how overrepresented Black Californians are in the unhoused population, despite only being a smaller part of the state population. You take that piece and you combine it with the fact that like care courts and the referral system could include, right, law enforcement interactions. People with untreated mental health illnesses are 16 times more likely to be killed by law enforcement officials. And thinking about the gaps in services just makes me want to strongly urge the commission to oppose care courts, just on the basis of thinking about how are these disparate impacts going to turn out for the communities that most need services in the future. So thank you, everyone.
Thank you, Rafael.
Andrea, your line is open. You may go ahead.
Hi, hello, commissioners. Thank you for hearing me today. I'm Andrea Wagner. I'm the executive director for the California Association of Mental Health Peer-Run Organizations. My pronouns are she or they. And I am here not only as an advocate for peers, but also as a parent of a child with mental health challenges and diagnosis, as a family member of a sister who's diagnosed with schizophrenia, and as a survivor of being homeless, impoverished, and in the incarceral system. So I have a lot of background in this. I've also worked in county mental health crisis services. I think we all could talk all day about all the flaws in this proposal. And I think you've seen that in many of the letters our groups have put forward, well-researched documentation about the issues in this proposal. What I wanted to just bring up today is that as the Oversight and Accountability Commission appointed by the governor to advise on the mental health system, we ask that you take a stand on this because working with the counties, that the myth that these counties are sitting on funds that they can spend on this is a myth. And we need to make it clear to the legislators who are operating under this, incorrect assumption that this MHSA money is there for grabs. It's not. And as been brought up, as a representative of peer-run organizations, we want that funding to go to the programs that work, and it's never been a priority to fund community-based organizations, and it should be. That is where the solutions are in the battlefield, tried and tested. And that is, I don't, to my knowledge, know that any of our consumer organizations were consulted before this proposal was proposed to the public. Until afterwards, we were asked to give input, but that input hasn't gone anywhere. And I've seen legislators sit on the stand and say, this goes against my conscience.
Thank you, Andrea. Your time is up. If you could wrap up your thoughts. Thank
just
you.
one last thought. But we're asking people to stand up to the governor. And you as a commission are in a good position to do that. So I ask that you do that today.
Thank you, Andrea.
Erica, your line is open. You may go ahead.
Hello and good afternoon almost, everyone. My name is Erica Cervantes, Program Manager for California State Policy at the Corporation for Supportive Housing. We are a national nonprofit organization focused on housing and homelessness. I am calling in today to oppose the current CARE Corp proposal, which fails to provide fundamental housing needs, robust supportive services, and fully funded intensive and voluntary treatment. Additionally, this proposal will fail to achieve the stated goal, as studies show coercive treatment is ineffective. It would perpetuate institutional racism and worsen health disparities. It would violate the autonomy and civil rights of people with mental health disabilities and would fail to address underfunded and inaccessible housing, health, and behavioral health systems. We recognize that the status quo is no longer acceptable, but to solve homelessness among people with mental health disabilities, we must invest in targeted, equitable housing and robust supportive services informed by those indirectly impacted communities. Thank you for your time.
Thank you, Erica.
Matt, your line is open. You may go ahead.
Thank you. Good almost afternoon, Chair and members. Matt Gallagher, Cowboy says he and his. I just want to begin by putting a few things on the record. On May 13th, 2022, I sent a letter to the Madam Chair, and I CC'd the Commission, the Executive Director, the Deputy Director, and the Commissioners, asking for a public hearing on CARE Court with a panel presentation from supporters, opposition, and those with concerns. For over a month, that email with the attached letter went unresponded to. Now, it wasn't until June 17th, 2022, over a month later, that I actually got a response. I then had a meeting with MHSA OAC staff, the Chief Counsel, the Deputy Director present for over an hour, and that was on June 20th, 2022. I asked for a hearing, a special presentation, a panel presentation with community members. At the end of that meeting, I was told I would hear a response back within a week. I heard no response. On July 13th, 2022, I spoke with Ms. Merrick and heard that there would be a presentation. And I emailed the Deputy Director at that time asking for an update. I received a response on July 15th stating that I would receive a follow-up email on Monday, July 18th. I have since still received no email. What this shows is a lack of transparency, a lack of accountability, and a real lack of an opportunity to show some real leadership on this issue. Since May, we have brought this issue to the forefront. We have asked the Commission to weigh in on it. And we have asked the Commission to hear from stakeholders, especially the advocacy groups that are funded from the Commission. This Commission spends millions of dollars each year on stakeholder advocacy contracts, and not one of them has been invited to speak on the presentation you heard today. That to me is telling. And the silence is deafening. This commission was created to be trustees of Mental Health Services Act services and funds. but yet you have been noticeably silent on issues related to the Mental Health Services Act. This proposal will divert funds from the Mental Health Services Act, and yet you do not vote on it. AB 2242 diverts MHSA funds for the LPS system, yet you remain silent on that bill as well.
Thank you, Matt. Your time is up. If you could wrap up your comments. Thank you.
I have no further comments, Tom. Thank you.
Thank you, Matt.
Steve, your line is open. You may go ahead.
Hi, my name's Steve McNally, and I'm live in Orange County. I am on a board, county-appointed behavioral health advisory board, but my comments are my own. Just trying to think, there's so much territory to cover. I guess I'm sort of disappointed that the leading voice for mental health accountability and oversight doesn't take a position or set the framework or determine how much MHSA money will be diverted. I'm also a little and that's not an indictment. It's just, I'm just a little confused. You know, if you said I'm appointed by a state agency that doesn't allow me to comment, I could accept that. I'm also a little confused. Like, we have mental health diversion, 1000 Penal Code 1001, 34 and 35. We don't have any idea of how that's working or not working across the state. We don't have a thorough analysis of AOT. And I bet if I took all the co-authors of this bill, much like the Be Well facility in Orange County that everybody in the world has visited, nobody knows the details about it. I bet they can't explain it or what they've signed on to. And when everyone who implements the bill is telling you they have major problems, that should be a very big red flag. So, and I've used a lot of systems. My family has. My son has schizophrenia. All his relationships are restored. I like to give that to others. There's a lot of unsafe adults in people's lives that have serious mental illness. And until people become a safe adult, you can't build trust and you can't have influence. And as far as NAMI California, I do a lot of volunteering for NAMI. It's inconsistent across the state how the message has been delivered. And 300 people, I've had 300 people go through one single support group that I host at a local, one group. So
thank you, Steve. Your time is up. If you could wrap up your comments.
And I will end up. Most people are very unaware of the topic even exists. So thank you again for always letting us share our opinions, and have a great day.
Thank you, Steve.
Deanne, your line is open. You may go ahead.
Hi, my name is Denise Choislot. I'm a youth advocate with California Coalition for Youth. CCY is asking that the administration increase the minimum age that the care court impacts adults to start at age 26 rather than the current age of 18. Transition age youth are still achieving development milestones defined as a period of growth marked by identity exploration, instability, self-focus, feelings of being in between, and optimism for the future. Research shows that their brain development is still occurring until the age of 25. The state has recognized that youth should be in at least the least restrictive setting as possible whenever possible, and other efforts are underway to encourage cross-system collaboration and critical behavioral health reforms through state initiatives, including CalAIM and CYBHI. While schizophrenia can occur at any age, the average age of onset tends to be in the late teens to early 20s for men and the late 20s and early 30s for women. Early identification and treatment are preferred so we can prevent young people from becoming chronically homeless and dealing untreated mental illness. We shouldn't be punting to a court intervention in order for communities to create necessary programs for youth. Thank you.
Thank you, Deanne.
Stacy, your line is open. You may go ahead.
Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. I urge the commission to take a vote on this bill. The California Behavioral Health Planning Council took a position on this bill, so I see no reason why the commission does not step up and take a vote on this bill. A couple days ago, the LA Times had an excellent op-ed that outlined very simply and clearly the reasons to oppose this measure. This in spite of the serious problem of so many people not having permanent housing in that county. I strongly urge the commissioners to read this op-ed. as the millions of dollars that will be spent to create yet another entire scheme in the judicial system could be instead spent on solutions that are proven. The Western Center on Law and Poverty has created a brief fact sheet that lists the alternatives that would address the issue in effective ways that are supported by the entire behavioral health community. I will make sure a copy of this is given to the commissioners. As Karis Myrick's presentation indicated so powerfully, this measure will have a disproportionate negative impact on communities of color, especially the African American Black community. Furthermore, this measure specifically allows for MHSA funds to be spent on this. The MHSA funding was never intended to be used for coercive or involuntary care. As someone who worked for Rusty Seelix, the principal co-author of this act, I say this with complete confidence. For these reasons alone, I believe the Commission should not be supporting such a measure. This also applies to the bill referred to earlier, AB 2242 by Santiago. This bill that provides that MHSA funding be used, again, for non-voluntary services. RUMCO believes strongly that this bill should have been heard by the Commission. It is not clear on what basis the Commission makes a decision whether to hear.
Thank you,
a
Stacy. Your
particular
time
vote
is
and
up.
vote
If you
on.
could wrap up your comments. Thank you.
Again, I urge the Commission to have the courage to take a vote on SB 1338 and 2242. Thank you.
Thank you, Stacy.
Karen, your line is open. You may go ahead.
Thank you. Karen Vicari from Mental Health America of California and the California Youth Empowerment Network, she, her pronouns. We second the comments of the people that have come before us, and we request that the Commission vote to oppose Care Court. Care Court follows the same failed approach of involuntary treatment and creates a costly program that provides no additional funding for services or supports, and which diverts MHSA funds from needed community-based services. We need to move beyond politics and create programs that will actually help people who have mental health challenges. There are no amendments to Care Court that will make this program effective because court-ordered treatment simply does not create long-term change. Like Kara said, it's like putting a Band-Aid on a bullet wound. The best long-term solution to help people with mental health challenges is recovery-oriented services, and recovery cannot be compelled or court-ordered. What we need in order to promote recovery is substantially more accessible, culturally responsive, community-based services. There are numerous examples of voluntary evidence-based programs that truly create long-term impacts. The most well-known examples are the Village and the AB 34 and 2034 programs. There's also a lot of research by Dr. Margaret Kushel at UCSF, who has found that high utilizers of services who are unhoused will accept voluntary voluntary supportive housing when it's offered. Care Court, like one of the previous commenters said, is particularly troublesome for transitional age youth, 18 to 25. Research shows that their brain development is still occurring until age 25. And the state has recognized that youth should be in the least restrictive setting as possible.
Thank you, Karen. Your time is up. If you could wrap up your comments.
Okay, thank you. For these reasons, we urge you please to take an opposition position on Care Court. Thank you.
Thank you, Karen.
Pashi, your line is open. You may go ahead.
Good afternoon. I think it is afternoon now. Pashi Walker, LGBTQ Program Director for Cal Voices. No matter what supporters of this bill say, Care Court is not an equity-based model and will create and continue multiple barriers for BIPOC, immigrant, and low-income communities to getting the treatment that actually prevents illness and promotes recovery from schizophrenia and other psychosis diagnoses. There is not enough time in 2 minutes to speak to all the objections to this bill, and my fellow advocates have and will name many of them. Although this is listed as an informational presentation, there are no number of amendments to this bill that would change the underlying premise that the research and so many advocates oppose. As Karis Merrick stated, you can't heal a gaping wound with a Band-Aid, no matter how many Band-Aids are put on this bill. There is still an underlying gaping wound that is not being addressed, especially for BIPOC, queer, trans, immigrant, and low-income communities. There is a reason this bill is so controversial, because it's a political Band-Aid with many potential negative consequences and not an effective path to prevention and recovery. The MHSOAC exists to protect the MHSA and the rights and needs of consumers. I hope you will not abdicate your voice on this matter. I, as well as many others have already done, recommend the MHSOAC vote to oppose, and do so today while there is still time to influence the trajectory of this bill, which will basically be a done deal by the time you meet again on August 25th. I know and recognize it's difficult to oppose a bill brought by the governor, and that you may be encouraged to either support or stay
Thank you,
neutral.
Pasha. Your time is up. If you can wrap up.
It's very important that you use your voice for this issue and not let politics have influence over what's best for consumers. There is historical precedence for opposing a bill, and your opposition would be taken very seriously. Thank you for letting me have the time.
Thank you, Pashi.
Vera, your line is open. You may go ahead.
Thank you. Thank you so much for your presentations. I am a peer specialist from Los Angeles County. I've been working in the public mental health system since the end of 2010. I consider myself a consumer member above all, and I am also an appointee to the California Behavioral Health Planning Council. I serve on the Workforce and Education Committee and was previously, until earlier this year, chairperson of the Housing and Homelessness Committee. I strongly suggest the commission oppose Care Court. Care Court, as Karis Myrick, everyone's pronouncing her name Merrick, it's Karis Myrick, had stated, Care Court, in my words, is like putting magic tape on a gaping, bloody wound. It's not going to do anything to help people in a system where the services are there, but the funding is not appropriate, the workforce is not there. We have to build up on what's already there, including peer services, which includes peer-run programs and peer respite to give people who may potentially be wards of the Care Court an opportunity to be understood in an environment with people who've lived experience with mental health issues. And nobody has said this, but I'm going to say it. I'm very curious as to why or how this Care Court came into being so close to 2024. I believe this is a political move, and I'm a huge supporter of Governor Newsom, but I pray that he is not banking.
Your time is up. Can you please wrap up your comments? Thanks.
I pray that he is not staking his political career on the backs of Black and brown people with mental health issues, especially when it's not going to help the issue of homelessness. Thank you very much.
Thank you, Vera.
Avery, your line is open. You may go ahead.
Thank you so much. Good afternoon, commissioners. I'm Avery Hulag Vicente. My pronouns are she, her. I'm the advocacy coordinator for CAMPRO, California Association of Mental Health Peer-Run Organizations. I also identify as a peer. We strongly oppose Care Court, obviously, and are against all forms of forced treatment. Court ordered is indeed an example of forced treatment, and self-determination and choice are both essential in someone's effective treatment and recovery. I'd like to reiterate what was shared by Ms. Karis Myrick earlier. Although people who identify as Black or African American make up 6.5% of the population in California, they account for 40% of the state's unhoused population. If passed, they will be overrepresented in a care court program, subjecting them to increased coercive treatment and perpetuating and accelerating our racially discriminatory health system. This care court agenda item undoubtedly needed to be an action item today. The information that was provided today and the comments from the many fellow MHSA partners and individuals who have spoken before me should be an indicator to you all that this bill is incredibly problematic and your influential voices can put a stop to it. Thank you for allowing me to speak.
Thank you.
Deb, your line is open. You may go ahead.
Deb Roth, Disability Rights California. Can you hear me?
Yes, we can hear you.
Okay, thank you. Disability Rights California urges the Commission to oppose care court. In 2019, many current care court supporters called for a state audit. 2 years ago, that audit said the problem is the failure of the state and counties to provide adequate care and housing. The Los Angeles Times said in an editorial then that the state should improve mental health care before forcing it on people. Make no mistake, even though care court is couched in terminology designed to sound voluntary, it is not. A few days ago, as Ms. Hiramoto stated, the Times published another editorial specifically opposing care court and called it a false promise. I'll align myself with the many points made by previous speakers about why care court is an awful idea and ask a question. My question is applicable to all of these points, but I want to focus on something Ms. Welch said about housing, because it is indicative of the problem with care court in a big picture. Is it going to work or isn't it kind of a way? With respect to whether housing would be guaranteed, Ms. Welch noted housing is not a right in California and care court is not going to solve that social policy issue. And then I believe she punted to the courts and all the authority the courts would have. So my question is, how can you possibly dare create a whole new system to bring a person under a court's jurisdiction with consequences for failure without making sure that everything you need to be successful is present? Thank you very much.
Thank you.
And we have our final comment. Adrienne, your line is open. You may go ahead.
Good afternoon, Commissioners. Adrienne Shilton, representing the California Alliance of Child and Family Services. We represent the community-based organizations across the state, the service providers who will be called upon to do the work as envisioned in this proposal. I want to thank the administration and Karis Myrick for their presentations today. We at the Alliance have been weighing in on this proposal since the beginning, and we do appreciate the administration engaging with us during that time. We would like to note, however, several key concerns from our perspective. First, we do not see the same protections that are offered under assistant outpatient treatment, and in particular around individuals being offered services first before the petition is filed. We find this extremely problematic, and we believe moving forward that care court needs to address this protection, as these individuals may very well engage in voluntary services first. We are concerned as well about the transition age youth being pulled into this program. The state has recognized that youth should be in the least restrictive setting whenever possible, and that there are other efforts in our state right now to address the youth behavioral health crisis. So we join CCY and Cayenne in the proposal to narrow this to exclude 18 to 25-year-olds. We also believe this proposal needs to have a much more robust evaluation and to be phased in so that we can truly understand who is being served, demographics of those being served, what is happening to them during the process, and are they being housed? And then lastly, we are concerned as well about the use of MHSA funds for involuntary services, as has been stated. Thank you very much.
Thank you, Adrienne.
We had 2 more comments that came in after the last comment. Ale, your line is open. You may go ahead.
Thank you. Good afternoon, everyone. My name is Ale Fernandez Garcia, pronouns they, them, and I'm with the California Pan-Ethnic Health Network. I'm a community advocacy manager that facilitates a statewide network called the Behavioral Health Equity Collaborative, made of incredible BIPOC-led organizations advocating for behavioral mental health in their communities statewide. I want to explicitly express that CPEN is formally opposed to care court. The words care and court simply never belong together and are highly problematic. I want to echo what many of my peers and colleagues have already said on this call, and I want to really uplift a comment that Ms. Myrick said, that care court is not looking actually at the root of recovery. It is more so looking to treat the symptoms. And so therefore it is not truly transformative, and we must explicitly name how care court will have a disproportionate impact on Black, Indigenous, people of color communities. Instead, we believe that trauma-informed, healing-centered, community-based practices should be at the center of treatment and recovery. So today I call for the commission to hold the governor accountable to hearing from advocates opposed to care courts and urge the commission to take a vote. Thank you so much.
And our last comment, Elizabeth, your line is open. You may go ahead.
Hi, I appreciate all the comments today, especially both the speakers. What I was actually hearing was that there was a lot of volunteer effort, and that it was a hope that the court would never have to be allowed, and that this would finally reach the level of severity of symptoms that a person may be experiencing, specifically 2 forms of psychosis, which tend to be persistent serious mental illness. And those are the very people that are not actually being served by the organizations and by the counties that we've heard speak in opposition to this today. So I'm calling in to say I do support this, in part because the existing services, even as beefed up as they are and expanded, which I do believe community treatment is the best pathway. However, for some people who are experiencing very severe symptoms, volunteering may not actually be a reasonable expectation at that moment in time, which is why I support care court, because without care court, what we have is we have criminal court and we have misdemeanor court. And I do believe Ms. Welch pointed that out quite well today. I believe she already addressed all the concerns by the opposition very carefully, and I believe the commission, the governor's office, and multiple input meetings from Disability Rights and Cal Voices, Mental Health America, from NAMI. There's been tons of information gathered, and a severe look at how do we keep this balanced and how do we still meet those needs of the most severe people that the MHSA funding was intended to reach in the beginning, and that money got siphoned off. It's much easier to show results and to feel good about yourselves as delivering services when you can say, oh, look, we helped all these 80% of the people. We don't have to worry about the other 10% or 6%. Especially dear to my heart because my daughter is in jail right now on criminal charges because she was incapable of volunteering, even with many soft touches. And it feels to me like the opposition is blaming
Elizabeth,
my daughter's
your time
illness
is up.
for not
Thank you for your
volunteering.
comments.
So I urge this committee to support care court. Thank you.
Thank you, Elizabeth.
And that was all of our virtual comments.
So I haven't done this, I think, ever. Now we have comments in the room. So I would ask that Lori Hallmark. Come to the podium. Thank you.
Can you hear me?
I can hear you fine.
So I'm Lori Hallmark, and I have a couple of things about care court. The first thing is that I would request in the people who can fill out a petition, that you put in some kind of provision that any spouse who has a history of domestic violence, whether it's against the individual they're filing the petition against or not, is that it must be identified, and that people who have a history of domestic violence, especially spouses, are not permitted to make that recommendation. The second thing I want to talk about is waiving appearances and waiving court hearings. It is obvious why it would be a benefit for people to be able to not attend the court hearing. However, in these type of situations, this is where it's incredibly important that we have effective communication between the lawyer and the client. This is a critical due process area, because if the person waives their ability to attend the hearing, and if they waive the status hearing, then they're not going to have the due process rights that they already should have. So that, if we could please make sure that that's really taken into account, that waiving a hearing is a really big deal. The last thing is when it comes into the accountability component, where a decision is made about the failure to successfully complete the program. Because that determination can affect due process in the future, 6 months down the road, if there's a court looking at whether or not this person should be involuntarily committed, they can take the decision of this person failed to successfully complete and use that as, as presumption. This is the opportunity to collect data and to find out, why did that person not comply with their plan? Why didn't it work? Were the services provided in a way that wasn't helpful? Was the quality of the services the problem? That's what it sounds like y'all are trying to get at with the accountability component. That
Karen, thank you. Your
right
time is
there,
up. If you can
grab
wrap
that
up.
data. Grab the data and have some real accountability and look at the quality instead of just the quantity of the services. This is the opportunity for that information. Thank you.
Thank you, Lori. Kevin Predge, please. I hope that was correct. Dredge, sorry, thank you. I saw a P. Sorry, thank you.
No problem. Penmanship is a little bit off. I've had a few surgeries and situations happen in my life. Anyway, my name's Kevin Dredge. I'm a public advocate, a children's advocate, and everybody else's advocate for mental health with veterans and everyone that's here today in our new realm. We've got blueprints and we have protocols. And just over the last locally controlled funding formula years and accountability plans with the local control formula funding, it's come to a disarray. So we're talking about prevention and early intervention. And when we look at the streets of Sacramento, I was born in Sacramento. I've got 2 kids, and that's why I'm standing up here. For my grandkids and your grandkids in the state that we live in, and that's the state of addiction for the most part. So to come together in an alliance with, we've got so many different organizations that are saying different things, opposing or saying yes or no or whatever it may be. We've come up with millions and millions and millions of people are dying of fentanyl. The Song for Charlie program is something that is a prevention and early intervention into our next generation. The Song for Charlie is a non-profit charity organization that has built a structure that will educate our students and family members into the new landscape of drugs. And I don't know if we're all aware of the drugs that are in the DEA's office right now. 98% of the drugs that have been confiscated contain fentanyl. And fentanyl is deadly. It's poison. It's causing murder. So right now we have over 10 million people of all races, of all colors.
Thank you, Kevin. Your time is up.
I do have these handouts that I would like to, if you would like a copy, I can give you one. No? Yeah, I'd appreciate that. Thank you. Any questions?
Thank you, Kevin.
Any questions?
Not at this time, but we will have him pass those out to us.
Thank
you so much. So we had the 2 comments in the room, and those are our final comments, correct, Mariani? Thank you. Okay, thank you so much for all of our public comment. And this has been a long process. So at this time, Toby, given everything that we have heard, I would ask that you continue to monitor with the team, the legislation, and come back to us and appraise us, explore how the commission can engage and support this and continue to hear what is going on so that we move forward with this. I mean, this is something that is obviously, I know commissioners are feeling strongly just so that we can continue to move forward and support this process. Thoughts on that as we continue to hear more?
Happy to do that. We'll monitor the legislation and the next item on the agenda is a discussion around full service partnerships. And I just want to point out that full service partnerships were designed to reduce incarceration, criminal justice involvement more generally. And so that's an aspect of our work that very much is related to the nature of this conversation, in addition to the prevention early intervention report that you've been working on. So we will, per your comments, monitor the legislation, let you know how it may change, and then come to you with some ideas of how the commission can stay engaged. Thank you.
Thank you. At this time, we are going to take a 10-minute break. Did you want to make a comment? Or you're just looking at me. We're going to take a 10-minute break. Stand up, take a break. So we'll be back in 10 minutes. Okay, thank you. An update on the progress made towards the implementation of a multi-county collaborative FSP innovation project. We will be hearing a presentation from Nicole Christie, who's the director at Third Sector Capital Partners Incorporated. Members of the public may request to make public comment on item 7 by clicking the raise hand button on your computer. Okay. Sorry, one moment. It's frozen. On your computer. Do you have it? Thank you. Once the public comment period starts, we will close the public comment queue. So please make requests to comment now or as early as possible during the presentation. With that, I would invite Nicole to go ahead and please get us started. Thank you. There you go.
Now
and
it is on.
Yes, and you might want to just bring it a little closer to yourself.
Very short, thank you.
Sure.
Well, thank you all for having us here today. My name is Nicole Christie. My pronouns are she and her, and I am a director at Third Sector, and I'm here with some of my county partners and my colleagues to talk about the Multi-County Full Service Partnership Innovation Project. Do we have the slides up? I just want to make sure. Okay. So if we can go to the next slide. Before I get started, I'm sure many folks are probably wondering who is Third Sector and why are we presenting today? So Third Sector is a national nonprofit technical assistance organization that advises our government agencies on effective ways to reshape policies and systems and services towards better outcomes for all people. And over the past 2 years, Third Sector has been supporting and continues to support the 8 counties that are in this multi-county collaborative. Next slide, please. So I will kick us off today with a bit of a project overview. What is this project and how it came to be? I will then turn it over to my partners from Fresno and Ventura to talk about the phases of the project, what we've accomplished, and also how we engage the community throughout the process. And then finally, my colleague Marissa will wrap us up with some lessons learned and our hopes for the future. I know we're behind schedule and we only have a limited amount of time, so I will try to be brief in my presentation, but these slides, as well as our 2-year progress report on the project, should be available to you in the presentation packet, and my email will also be shared at the end of the presentation for any further follow-ups. So, next slide, please. This project is all about full service partnerships, or FSPs, which are the programs that, as I'm sure many of you know, serve over 60,000 individuals with severe mental illness across the state. And FSBs really take that whatever it takes approach to provide a wide array of services that are aimed to help individuals' recovery goals. And so, because FSPs are really tailored to the individual, counties are provided a lot of flexibility in how they operate their programs, which is a great thing for community responsive services. That flexibility, however, can sometimes lead to inconsistent practices or policies or data, which can make it really hard to tell overall how FSPs are impacting folks. And so from that challenge grew this multi-county FSP innovation project. And if you go to the next slide, back in 2018, we, Third Sector, partnered with LA County to really think about how to shift FSP services and contracts towards outcomes. From that, in 2020, 6 counties then came together: Fresno, Sacramento, San Bernardino, San Mateo, Siskiyou, and Ventura, to form this multi-county collaborative and to build on the efforts in LA. And then actually in the fall of last year, we had 2 additional counties, Lake and Stanislaus, join in these efforts. Next slide, please. So really what I'll leave you with as the overview, at the end of the day, what this project is trying to achieve is help counties improve their ability to collect and use FSP data in a meaningful way. So understand who they are serving, how they are serving them, and if those services are actually improving the lives of the consumers. And with that, I'm going to turn it over to our partner, Sloan Burt from Ventura County. She was not able to be present with us today, but she is virtually attending.
Sloan, you are unmuted.
Good afternoon. Can you guys see and hear me now?
Yes, we can.
Okay, great. If you could move to the next slide. Just so you know, my name, as you said, is Sloan Burt, and I'm the Quality Improvement Manager with Ventura County Behavioral Health, and I've been involved in this project at our county level and at the cohort level since its very beginning. And along that line, I wanted to share a little bit about what this project has looked like since it began in 2020. There's 4 phases to the project. The first 3 include the landscape assessment, implementation, and sustainability planning, which I'll speak a little bit more about in a moment. And then currently we're in an evaluation period where we're really looking at the impact of the work that was done at the cohort and the county level. On the next slide. So the landscape assessment was a really critical component, a really important part of this project. With the landscape assessment, all 6 counties who were in the original group, with the support of Third Sector, began to collect information to better understand their FSP programs, to really take a close look at our services, the way that we're implementing them at an operational level, how it's impacting our clients, and then where we can see that there's opportunities to grow, which led to the implementation activity selection, both again at the county level, but also at the cohort and state level. This was a really, really unique opportunity to take that very close, focused look at what we're doing and to understand how it's similar and different across counties. I'll take the next slide. So as part of the landscape assessment, one of the first steps was engaging the community. And that was a high priority for this project and to support FSP efforts. And so all of the activities that took place from that point forward were really rooted in the feedback that we got during the community engagement piece of the landscape assessment. And so it helped us to really hear from the community, from FSP clients, past and present themselves, from caregivers, peer advocates, and providers, so that the information that they shared, in addition to kind of other things that we learned about our own programs and services, could be the foundation of what we were doing. And so as you can see, the third sector was able to support the counties in doing something that we otherwise would not have been able to do. We wouldn't have the capacity to really take a look at our programs and services in this way. So in total, across the 6 counties, there were 179 individual interviews. There were 39 different focus groups and 123 staff responses. So this yielded a very robust set of data and information, both qualitative and quantitative, that helped us to understand what we were doing or what our FSP programs and service delivery was looking at, and what was needed as far as planning to inform next steps. Take the next slide. So what you see on this slide and the next slide we pulled some quotes just to demonstrate the rich information that was gained through the interviews. For example, when we really got to hear how FSP clients, their feedback, what worked, what they would like to have more of, how it supported them in their own journeys, as well as how how they worked with the counties in their implementation, how that informed what would become shared outcomes, process measures, and metrics to look at this project again at the cohort and county level. Next slide. One thing that kind of emerged from the landscape assessment and the community engagement was the importance, as we know, but to really see it kind of described and defined through this detailed information we collected, had to do with client transition and their need to have very clear step-down guidelines at the county level to support them in their journey. At the time that clients may be ready to step down or graduate, transition out of FSP, that it can be both a time of pride and anxiety. And so hearing from clients themselves really gave us a lot of information where we could learn what happened in our own county, but also in other counties, and how that could be used to inform recovery-oriented guidelines and processes. So we're making adjustments as we go, not just based on what we think will work or what we want to work, but based on what we hear from our community and our clients. Next slide. So once we had gathered the information through the landscape assessment, we moved into design and implementation. And from the information that was gathered in the first part, that counties agreed to focus on a few key areas at the cohort level. And so the 3 areas that you see here ended up creating work groups where each work group convened many times over many months to achieve a goal. So the first one was around FSP populations and definitions. There's losing the word right now, the guidelines, the regulations, that's the word, that kind of generally describes this, as Nicole mentioned. County by county implementation can look different, and the way that they interpret those look different. So what the cohort group did is to help kind of standardize, to share what they use and what they have found works or doesn't work, and come up with some standardized definitions that then could be applied back to their work at the county level. We also focused on outcomes and process measure metrics. So we're collecting a lot of data, sometimes a lot of different data, and different counties are in different places as far as how they're able to use and apply the data that they receive or they have on FSP compliance. So we collectively discussed what are some priority outcomes and process measures so that not only as a group, but also at the county level, we could continue to build our understanding of the impact of FSP services. We also convened to discuss some statewide recommendations on data related to the data collection and reporting, or DCR forms, which are very extensive, collect a lot of information, and are intended to be collected pretty regularly from clients. And so we talked through what's working, what's not working with those, and ultimately identified some recommendations for long and short-term goals that could be put into place to help counties do their best job to collect the data and use the data that is intended to be in those DCR forms. Next slide. So in going back to this idea of outcomes and measures, along the line of what kind of the main goals of FSP are, we identified, again, using all the information available to us through the landscape assessment and whatnot, the areas that we wanted to focus on across counties, which are increased stable housing, reduced justice involvement, reduced psychiatric or utilization of psychiatric facilities, and also increased social connectedness. And what we did was spend a lot of time talking about what does this look like? How are we going to measure or mark increased stable housing, for example? And how can we learn more about whether FSP helps clients feel an increased social connectedness, which is an important goal in working with people who are part of FSP programs. And so some of the information we agreed on would come from the DCR, as I mentioned in the last slide, but also we agreed, for example, with the psychiatric hospitalization data, that pulling from our own electronic health records would produce a more robust and reliable data source so that we could take a good look at the impact of FSP on hospitalizations. And then lastly, with the increased social connectedness, there wasn't a particular measure across counties or on the DCR forms that really looked at this. So what was unique about the opportunity we had through this project is that the counties agreed that on one of the DCR forms, we would add this measure, we would add this item so that we could start collecting it if we weren't already collecting it. And then we would eventually have data that could be used at our local level, but also across counties. And I think, can you move to the next slide? I believe at this point I'm handing it over to my colleague. Yes, so I'm going to hand it over to Erin Chan Golston, who from Fresno County, to talk more about their local implementation.
All right, good afternoon, not morning. I'm Erin Chan Golston. I'm the MHSA coordinator for Fresno County. So in addition to the work that our counties did as a cohort, each county also received some technical assistance to pursue initiatives that addressed our unique local challenges. These initiatives were based on county staff needs and, very importantly, community engagement, as Sloan mentioned. This slide gives you an overview of the initiatives that each of the 6 counties selected. I won't read it to you based on our time constraints, but you can look at it later. As you can see, there were some common themes. So for example, 5 of our 6 counties chose to look at step-down and graduation guidelines and to evaluate those within their own local contexts. So even though these initiatives look different between each county, we were able to share our knowledge with one another through the process. Next slide, please. So Fresno County chose to work on 3 local implementation activities based on our staff feedback and our community engagement. So we have our reauthorization activity, which was a process to meet with our providers at regular intervals to assess where the individuals receiving FSP services were in their treatment plans and to better reassess reauthorization needs. We also looked at child referral and enrollment to really streamline that system and make it even easier to navigate for the families that are seeking services for their children. And then finally, we looked at data collection and reporting. So this actually ended up being a very exciting initiative. It was well received both at the county level and with our providers. The providers were really excited about this data collection and reporting. So if we move on to the next slide, I will highlight that a little bit more. So our data collection and reporting activity resulted in some revamped meetings and new tools to more collaboratively review and discuss data with our provider community. So Fresno County has been working on creating interactive data dashboards. We just switched software, so our dashboards are being rebuilt in our new software, but these can be accessed in real time by our providers, and they can be filtered by demographic variables such as race and zip code. Fresno County created our FSPs in such a way that we have, for example, a rural mental health system that offers FSP services. So that's really important for those communities that look different, that have specific needs when compared to, like, urban Fresno. We also have dedicated data meetings. So once a month, providers meet with their contract analysts and any other county staff that they need to discuss their specific needs and trends. But now we have implemented these new quarterly continuous improvement meetings with all of our providers. So we literally get every single FSP provider together in one 3-hour Zoom meeting, and we have staff from our quality assurance division, we have staff from contracts division, and several other divisions on hand so that we can all meet in the same place. And what's actually been really exciting about these meetings is while we're intending to look at data trends across the system, we've been able to address what could seem like a minor issue, but is actually affecting our ability to provide services and ability to collect data. So some of our staff worked very diligently with our providers at our first data meeting to address some communication issues with the hospital. It wasn't that the hospital was doing anything wrong with their referrals, but there were ways that we could improve the referrals that would actually help our providers provide better and more appropriate services quicker, because they didn't have to go look for more information on the people they were serving. So it actually improved the speed by which people could get assessed and get into the most appropriate treatment. After this new quarterly meeting, we're going to be working with our probation department to do the same thing. Like, what does a probation referral look like? What works for their system, but also really what helps get the best mental health treatment fastest to the people who need it. All right, next slide, please. So, of course, kind of going back out, zooming out into our multi-county section of the project again, we really wanted to make sure after we did the implementation phase of this project that we had sustainability planning in place. So some of the methods that we used to look at this were to plan for the RAND Corporation's 2.5-year evaluation of the project and to create a continuous improvement process that enables counties to continue to share our data on a regular basis. As part of this phase, we are able to customize our DCR reports to measure the specific outcomes that we designed as a cohort. By running these reports, each county will be looking at the same data in the same way to elevate the trends and share best practices. Counties also created a recurring learning community that's a space for us to reconvene, troubleshoot, review data, and come together as a group with the support of RAND and Third Sector. And then next slide. So what this looks like in a timeline overall, after Third Sector's technical assistance period completed at the end of 2021, we moved into our 2.5-year evaluation phase. So that's where we are right now. The RAND Corporation is going to conduct quantitative and qualitative analyses to assess participant outcomes, and they plan to release the final evaluation results of our project in 2024. So now I will turn it over to Marissa, who is a manager with Third Sector, and she will discuss some of our lessons learned over the course of our project.
Thanks, Erin. I'm Marissa Williams. I'm a manager with Third Sector, and I've been working on the multi-county project for a little over a year now. And if we could move to the next slide. I wanted to leave you all with some thoughts on the lessons learned throughout this project and the insights that we have, particularly on this concept of the multi-county collaboration. So this collaborative had originally 6 counties and now 8 counties, with joining Lake and Stanislaus. And really, we found that while it was definitely a challenge to balance the needs of all 6 counties in the cohort, we came away from the project with a strong feeling that the cohort model offered a lot of great opportunities for cross-county work while balancing the need for individualized support across counties in a local context. So there's a lot of value to doing the cross-county work when there are shared vision and goals. And I think the DCR work was a really great example of that. The counties came together and really assessed what are their challenges with data collection and reporting, and how could they advocate for changes that would be helpful both in the short term and the long term. And at the same time, each county has unique needs and resources, and it's really important to provide that individual support as well and be able to identify where standardization is a good idea when local customization is better. So, for example, the standardizing of the specific outcome measures was really important because the goal was to allow for that cross-county learning and for folks to be comparing the same data across county so that they could really understand the impact of their programs and how consumers were impacted. Other challenges, like the referrals processes, for example, are really very county specific, and so it makes sense to focus in on an individual county when doing that type of work. I also wanted to highlight that the cohort approach also created a lot of space for informal connections that have been really valuable. We have continued to see folks reaching out to each other and sharing best practices and able to really connect in a way that they weren't before this project. Next slide, please. As we've already mentioned, community engagement was a really core piece of the multi-county FSP innovation project, and we wanted to be sure to highlight some of the key lessons learned from this aspect of the project. So engaging folks early and often, we often hear a lot about engaging consumers for feedback after a plan has been developed, and we really thought it was important to engage consumers right off the bat and to understand their needs and goals for their participation in FSP services before we even began thinking about solutions. We also thought it was important to consider compensating folks for their engagement. In the multi-county project, we compensated all of the consumers that were engaged with gift cards to really value the input that they were providing and the expertise that they're providing on their own experience. We also wanted to ensure that folks who were conducting the engagement had the right training on cultural competence and trauma-informed interviewing to support consumers to be able to engage in a safe way and leverage agency and third-party staff to meet those different needs. Next slide. So where are we going from here? So we wanted to leave you with a little bit of understanding of where this project is and what's moving forward. So Erin mentioned that the first wave of counties are currently in that evaluation phase. We also have 2 new counties who have joined the innovation project. Lake and Stanislaus counties joined in the fall of last year, and so they have just wrapped up their landscape assessments, and we're really excited to be diving into implementation activities with them. We're also working on growing the statewide learning communities. As a part of the project, counties came together in learning communities to share across counties, and that's an effort that will continue. And lastly, counties are continuing to explore opportunities for statewide change. So the efforts around the DCR are one example of that, where counties are continuing to engage in how they can improve data collection moving forward on a statewide level. And so we're really excited about all of the opportunities that this project brought and will continue to bring. And we'll open up for any questions that folks might have.
Thank you so much. Thank you for being here in that informative presentation. At this time, I'm going to ask if there are any commissioner questions or comments. Please, Commissioner Carnevale.
thinking about was, in addition to the sort of process and the outcome data, what would be really interesting would be, and I told you to laugh at this, when we think about what our capability is at UCSF, if we could take it another step further and start to measure the social and emotional health.
I'm sorry, Commissioner, thank you.
This off, if we could measure the social and emotional health of the people that are going through these programs, which is very possible to do, then we're not just tracking the transactional outcomes, but we're actually starting to track the health outcomes and getting at some of the root cause issues, which would then lead to more precision interventions. So then we've covered the complete cycle of the activities. So this would be like an enhancement on top of this, could really provide a wealth of data that would be much more actionable in the long run. So it's more of a, it's maybe a 2.0 idea, but something I think would be very, very possible. So thank you for all the work you're doing on this.
Thank you, Commissioner Carnevale. Any other comments or questions from my fellow commissioners?
We have a comment from Commissioner Rolette online.
Thank you. Please, Commissioner Rolette.
Thank you, Chair. And my apologies to the commissioners. I had some technical difficulties earlier, and if the chair allows, I'll make some very, very brief comments regarding SB 1338 at the end of the meeting, and they'll be very brief. Regarding this presentation, I appreciate the social determinants being referenced, not directly, but certainly indirectly, and was wondering, as Commissioner Carnevale referenced, he talked about transactional outcomes, and forgive the paraphrase, but was there a flourishing scale utilized to query the perspective of people who are FSP participants? And for full disclosure, the agency that I'm privileged to be a part of does operate FSP programs in Stanislaus County, one of the counties that will be joining this collaborative.
Sure. I just want to make sure I understand your question before I answer it. So are you asking about how we spoke to the folks? Are you asking, can you just be a little more specific so I make sure I answer your question
So
correctly?
oftentimes when we query the perspective of individuals who are part of FSPs, and in this case, you're querying the perspective of counties to get data, they talk about outcome reporting scales that they use. And typically they're fairly traditional and in nature. And if you don't know the answer to this question, you can tell me that. Were people incarcerated? Were people housed? Were people out of the hospital? But they don't point and ask directly from the perspective of the participant in the FSP. Do you think you're flourishing by virtue of your participation? And so that is I state my question, I hopefully better this time. Where did they go out of their way, or was there an effort to garner the perspective of the participants of the FSP to the individuals who are giving you this information?
Yes. Okay. Thank you so much for the clarification there. And I can answer that in a couple of ways. One, when we did a couple of rounds of consumer engagement, and some of the questions directly were, what are your goals for the program? Do you believe the program is helping you to achieve those goals? What makes you feel stable, or what does recovery feel like to you? So we got a lot of rich information in that way. The other answer I think I can provide is that, Sloan showed that slide with the handful of measures that the counties are looking at in a consistent way, and housing, justice, hospitalizations are on there, but the addition of that social connectedness measure was really one that came through from consumers. We really heard them say being a part of a community makes me feel like I'm on the right path, makes me feel comfort. And so the addition of that measure, I think, is very new and unique to a lot of counties. It's not necessarily being measured consistently. And so our hope is that that measure is a bridge to maybe some additional things that really focus on kind of the social emotional health, like you mentioned. But I don't know, Erin or Marissa or Sloan, if you have anything you want to add to that.
I can just add to Commissioner Rolette, we are talking about the same thing, and there's a whole neuroscience of relationships, which is a huge part of assessing social emotional health, and there's a lot of work in this area, and it can go much deeper beyond just asking, if somebody's happy. There are lots of scientific ways to evaluate their mental, social, emotional health, and that's what would be great, to get to that level.
Thank you, Commissioner Carnevale. Commissioner Rolette, was your question answered? Was that very much? Yes?
Yes.
Okay. Thank you. Okay. Okay, so let's see. Yes, please, Commissioner Mitchell.
That increased social connectedness, it did stand out to me as well. Because again, everything we do, I think about my own kid who's very isolated. And so are you saying that you guys added this particular, let's say, dashboard identifier, so all counties that are in the study now will be, are in the data collection, will now be asking this question? And that's what came out of the collaborative?
That's correct. It's been
Okay.
added to one of the DCR forms that are required, and so it's now a question for these counties on their
That's
DCR.
great. That's very good.
And if I
Thank you.
can,
Oh, yeah.
sorry, if I can just add something additional to that one of the things that Third Sector helped counties do was to do what we called a measurability assessment. So as you may know, every county kind of collects data in slightly different ways, or the assessment measures that they use may be slightly different. And so some things like you guys are speaking to, whether it's the social connectedness or feeling like, are they improving, that they're collected by counties in different ways, but it wasn't a particular measure where we could find like a consistency about how everyone was collecting it in a way that we could look at it collectively. So I just want to acknowledge that some of the things that you're speaking to are